Joe. I'd just like to welcome everybody. It's wonderful to see such a crowd of people interested, so many people out there interested in the cause. And I really want to thank the Alleghany Health Network for allowing us to use this beautiful venue and partnering with us and being so helpful. All the volunteers, all the staff of the Alleghany Health Network and the Autoimmunity Center, and the ARDA staff and volunteers that, and also all the speakers that will be coming before you to make their presentations. I always like to mention, they do this as a volunteer. We don't pay honorariums. So they give up a weekend, they travel from around the country to come and speak to patients, and that's real dedication. That just shows you how much they care about their patients. So I'm going to just tell you then with that a little bit about ARDA, the American Autoimmune Related Diseases Association. We're 29 years old. I'm actually the founder. And I'll just give you a little very short history of why. I'm a lupus patient. I've collected a few other autoimmune diseases along the way. I was diagnosed many in my early 20s. So for all of you out there that have a fear when you're diagnosed, I remember the doctor telling my husband, maybe I had 6 months. And then maybe she'll make it to 30. And then it was 40. And I outlived all three of those doctors. So, so here I am. And I had been involved in the founding of the Lupus Foundation of America, served as this, finally to the point of serving as the president of the national organization. And it was from that perspective, and my family, I happen to come from a very large family. Nowadays, it's a humongous family. I have 13 siblings. quite a family. But we had several autoimmune diseases. So I had another sister with lupus. I had two brothers with severe psoriasis. I had a sister that had autoimmune liver disease. And I just couldn't understand why we were not looking at these as a disease category. And the word autoimmune was almost a foreign word, and it certainly wasn't something known to the public. In fact, I live in Michigan, Detroit, so everybody thought I was starting an automobile club. So, or did you get this from an automobile? So that was what was behind it. Why were we not looking at this more collectively? What was the common thread? Was there a genetic background, which at that time there was not thought to be one? But I looked at my family and thought we could not be this unlucky to have all these different autoimmune diseases. So that was the impetus, because at that time there was very little collaboration. When I would contact NIH, one of the institutes, they'd say, well, we handle type 1 diabetes, and they'd name one autoimmune disease. Oh, we handle rheumatoid arthritis. So there was very little coordination at the National Institute of Health. The figure they gave me for the numbers of people with autoimmune diseases was very, very low. I knew it had to be much more than that. And then when you looked at the patient groups, they were like the Lupus Foundation and Arthritis Foundation. They were all out there working very hard, advocating for their particular disease or diseases that came under their auspices, but they weren't really working together. And in an advocacy, our voice was pretty small. Each one of those groups had a very small voice. So that too was, my interest was in bringing about collaboration. I think I learned that from being in a big family, that collaboration, I like to say 2 and 2 make 6 when you collaborate. And so that was the goal behind it, to see autoimmune disease recognized as the disease category representing the 50 million people that are out there with these diseases, to have it recognized as a disease group so we could increase research, because we still do not really understand the mechanism behind autoimmune disease. We know a lot about autoimmune diseases, but we still need to get to that. Well, in that time, from that time of that founding, now many of the therapies that are used in one disease are used in another disease that is completely outside of the specialty of the first disease. Because I also found that specialists didn't talk to each other. The researchers looking at MS didn't talk to the researchers looking at and researching lupus. In fact, I once asked a question, well, has this treatment ever been tried in MS? and I was with a whole group of doctors and researchers that were looking at MS. And they looked at it, and they goes, no, but it should be. And I thought, yes, it should be. And so that was what was behind it. The 29 years ago, we've come a long ways. There's been a paradigm shift. You know that you have arrived at least with your goal of having autoimmune disease recognized as the disease category when the news release is Kardashian may have an autoimmune disease called lupus, instead of she may have lupus, an autoimmune disease. 29 years ago, you would have never even heard the word autoimmune. So that connection. So that brings us to where we are today. Today, it is recognized because the public even recognizes that families recognize autoimmune disease within their family. They are starting to put together, and we've had many campaigns about know your family's AQ. So meaning your autoimmune quotient. And look at, because we still, to this day, have a significant problem in diagnosis of autoimmune disease. It still takes 3 years and four doctors, and we do this survey every 5 years. It used to be like 7 years and 10 doctors and over a long period of time. So we've shortened it, but not enough. Well, that has to get down. There's a reason to follow a patient until the disease declares itself, but until somebody thinks about it, you never even get on that path. And that's what happens, is people, they don't think about the disease at first because the symptoms can mimic many other conditions. So that's why knowing your family history and being able to present that to a physician, because it's usually still not in a health history. We still have that hurdle to go. So the diagnosis is still a problem. We still have a long ways to go. And then one of the goals back at the beginning was, why don't we have a place where patients can go and see any different specialist? Why do we have to, as patients, be coordinating our own care, going from specialist to specialist? Because if you have an autoimmune disease, you may have to see a rheumatologist and a dermatologist and a nephrologist, sometimes throw in the neurologist. And you end up having to coordinate that. And that is not a good way to handle and be treated for a serious chronic illness. So when the history of the Alleghany Health Network and the Autoimmunity Institute, we'll go back just now, 2.5 years, I was on vacation. They put out a press release that they were going to have an autoimmune institute that was multi-specialist. People could come, see any different specialist, hopefully get diagnosed, hopefully have coordinated care, and hopefully save costs, because the cost of uncoordinated care, seeing all these specialists, is very expensive. And insurance love to start denying things. And so that was a day. I was on vacation. I remember being in some hokey little store with knickknacks, and we were having this long conversation about, we couldn't agree more on how needed this was, because ARDA had actually approached several different institutes over the years trying to form such a thing, and it was always came down to the bean counter saying it was too expensive. So with that, we really owe Joe, Dr. Ahern here, a big hand, because he told me about 9 years to convince everybody. And I understand that. It was a little bit of a hard sell. But anyway, that's why we're here today. Thank you very much.
Thank you, Virginia. So we are thrilled to be welcoming Virginia and ARDA, and ARDA's board of directors is seated throughout the audience. And so they're based in Michigan. These board members have come from around the country to be with us today and tomorrow for our walk. So as you know, the theme today is what every American needs to know about autoimmune disease. In particular, our speakers are going to be focusing on holistic care for autoimmune disease. So why are we here? We're here for you. We're here for our patients. Our motto is treat the disease, care for the patient. Jessica here, one of Dr. Manzi's lupus patients, she died of a massive myocardial infarction the night before Thanksgiving several years ago. So Jessica's no longer with us. So that's why we're here, because we have patients who aren't going to be with us tomorrow, and we have to put ourselves out of business. So thank you for joining us today. We're going to give you a different perspective than you might have heard before about caring for the patient. I have to tell you, this is not Arda's first visit here. So this was May 24th, 2018, when we had our ribbon cutting for the Autoimmunity Institute, and hopefully after the forum, you'll join us on the second floor. You'll join us on the second floor for a tour. So you'll recognize Virginia Ladd here cutting the ribbon, and then right behind her, Mike Lynn, one of our biggest advocates, who is a ARDA board member and with us here today. So Virginia spoke passionately at the ribbon cutting, and her remarks were very similar to what you just heard. She was, after we had our press release, she was the first person to respond when she was on vacation. And she has been a huge advocate, telling the whole country and even the world about us here in Pittsburgh. So this is our waiting room. Again, you should come visit us. It's unique in the world. There's nothing like it. There never has been, and we're extremely proud of that. And I have to tell you that ARDA has not just supported us verbally and vocally, but they've supported us financially. And this, at the ribbon cutting, here's Virginia and Mike and Dr. Manzi, supporting us with more than $250,000 to study the cost of autoimmunity. So a huge thanks for ARDA. That study is going to be launching in the first quarter of 2020, and we're going to be interviewing patients and determining how many misdiagnoses, how many physicians, how many imaging tests, how many blood tests, how many medications that were wrong, how many days missed from work, et cetera, et cetera. You're going to be hearing more about this. I also want to recognize our Alleghany Health Network Autoimmune Institute team. We have so many team members that are here on a Saturday morning supporting us, and we're thrilled. Hopefully you'll have a chance to meet them. You met Candace Harrington and Emily Caruso at Check-In. They direct our public relations marketing efforts. We also have Jan Ferry, who directs our patient care. Linda Santalisa and her daughter here, who directs our research. I hope I don't miss anyone because I saw people still coming in, but we have Laura and Dawn and Terry and Paige and Stephanie and Nicole. So great representation from our team. And also thanking Larry O'Leary, who's back there, who's taking photos, and he'll be available afterwards. We're videotaping this event, and so thank you, Larry, for our audiovisual support. And if you don't already know, if you haven't already registered, tomorrow it should be a gorgeous day. Shenley Plaza, 1 o'clock launch, registration prior to that, so please join us for the walk. So our first speaker, Dr. Susan Manzi, is chair of our Medicine Institute, and she directs the Alleghany Health Network Autoimmune Institute Lupus Center of Excellence. She's also the chair of the board of directors of the Lupus Foundation of America. Dr. Manzi is a graduate at the University of Notre Dame, University of Pittsburgh School of Medicine. She completed her training in internal medicine at Duke University Medical Center, her rheumatology fellowship, University of Pittsburgh Medical Center. She received her master's of public health from the University of Pittsburgh. I could go on, but let me tell you that Dr. Manzi has cared for patients with autoimmune disease from across the United States, more than 40 of the United States and 14 different countries. And she is committed, I know. And I know. Yeah, we told them that's the prompt to go. No, she doesn't need any prompting, but she is committed to transforming how we care for our patients. So I give you Dr. Manzi.
Put my name tag up. So good morning, everyone. Thank you for being here. I echo all of Dr. Ahern's thanks, Virginia, Arda, the whole team, and all of my patients and friends and colleagues and speakers. It's really a pleasure to have you today. But in the interest of time, I'm going to move forward, and my charge today was to talk to you about how we at AHN are transforming care. And I think we all know that healthcare could be better, not necessarily the kind of healthcare we deliver in the United States, but the way we deliver it. It seems to be in need of improvement, and we're trying very hard to do that. But before I start, I just want to, we always talk about autoimmunity. People sort of know what it is, but they're not 100% sure they've heard of it. I'm not quite sure why it happens. And so I'm going to just take a few slides to talk a little bit about that. We have some great speakers today. By the time you leave, you're going to know so much more than when you walked in the door, trust me. So I always use this slide. Actually, last weekend we were in Michigan and talking to the nursing school at Northern Michigan University, and I always start with this slide because I think it really depicts what autoimmunity is. So this is a young woman, and it could be a man as well, but inside of a castle, and instead of the artillery pointing outward to fight against things that don't belong, it's pointing in. And so it's that idea of your immune system attacking self. And we call these greater than 100 diseases of self-sabotage. And what's interesting is that your immune system, it's very hard for your immune system because what it's trying to do is get rid of external invaders that don't belong, and yet at the same time be able to recognize not to attack you. And so it's trying to look out there, what's bad and what's good, and how do I distinguish the difference? Because without an immune system, we know what happens. You've heard of AIDS, right? HIV. Those are people that have no depleted immune systems, and they get horrendous infections, and for a while it was a fatal disease. This is almost the opposite, right? Where the immune system is overactive in many ways, trying to distinguish self from foreign things that don't belong. And so it's difficult to do. Some people do it better than others, and the ones that don't develop autoimmune diseases. And the other thing I mentioned is what makes it so mysterious is you understand heart disease. People understand stroke. You point to your brain, you point to your heart, you know where your kidneys are, pretty much. So you know where these organ systems are. But if we say point to your immune system, where do you point? It's really everywhere, right? It's these intricate cells that travel through the body that are there to be your surveillance cameras. And so it becomes a very, very complex system. This is the only slide I'm going to show that makes your head spin. This isn't science class, I promise. But you're very sophisticated. Patients are sophisticated. They want really to understand more. And this is a very simple model, and let me just walk you through it. Here is the bad guy, right? This is a bacteria, gets into your blood system. Your immune system says, nope, gotta go, right? We gotta get rid of that. So the B cell, I guess there's no way of minimizing this, but anyway, the B cell is here. This is a very important white blood cell that sees this bacteria and says, I gotta get rid of it. So this cell makes all of these little, see these little white, these little yellow dots here, those are basically making antibodies to attack. They want to get rid of that bacteria and get rid of it. That's the ammunition against the bacteria. But what happens in autoimmune, and then once that happens, once these bacteria are coated here, then this cell comes along, eats it, and gets rid of it. So now you're good, right? What happens in autoimmunity is that, see self down here, if you can see this is you. The immune system gets confused and starts making antibodies to you. And what also happens is when the antibodies attack your proteins and cells, they don't get cleared away. They float around. And so this becomes chronic disease in many ways. It's not cured. And so this is sort of in a nutshell what happens in autoimmunity. And so people always say, why? Why do I get autoimmune diseases? Well, as Virginia said, a big part of it is genetic. no question about it. And unfortunately, you can't change your genes. They're your genes. They're what you inherited from your parents and other relatives. But they play a big role. But it's not just genes, because we know, especially just as an example in lupus, if you look at twins, can you all see the screen? There, okay, I didn't want this man. When you look at twins, identical twins with lupus, if one has lupus, the chance of the other one having it is a flip of a coin, 50%. So that can't be purely genetic, because identical twins have the same genes. So what we know is that genetics is important, but the environment, some trigger in the environment probably sets it off. We know, for example, in lupus that sun is bad. Sun can hit you and cause flares of disease, onset of disease, but other things can also trigger. We think chemicals in the environment. And there's also gender factors, because typically autoimmune diseases are primarily in women, a lot in women. Not all of them. Some are even more common in men, but a lot of them. So gender becomes a factor depending on what the autoimmune disease is, whether you're male or female. But this is something you can control, right? We can control this by our sunscreens and avoidance or other environmental triggers that we learn about. But you can definitely control this. And you're going to hear from Dr. Betsy O'Neill today, who's wonderful, who's going to talk to you about lifestyle, food, what you eat, what you do that can definitely impact your immune system. So, for example, we know that people that smoke have a much higher incidence of rheumatoid arthritis, even children that are exposed to secondhand smoke. So there's a lot of things that you can control. So, autoimmune diseases, why are they so complicated? Why do we have the Autoimmunity Institute? Because that attack against self can happen in any organ of the body. And depending on what it targets, that's the disease. If it targets your thyroid, autoimmune thyroid disease, right? If it targets the brain, multiple sclerosis. So it depends on the target, and that's the disease that manifests. But this is why we need all the subspecialty doctors practicing under one roof. We also know that if you have one autoimmune disease, you're more likely to get another. So many people have celiac and this, or thyroid and that. We also know that because families have these diseases, it's nice to have one place where all family members can come as well. So I put this up because I Googled healthcare, and I got all these sites. I had to put it up about people talking about the broken healthcare system in the United States. And I'm always careful to say that, because I think we have the best healthcare in terms of innovation and curing diseases, and what we're doing in cancer is extraordinary. Even the advances we've made in autoimmune diseases. The care we give is great, but as I said before, the delivery system is broken. And I don't think anybody that has been a patient anywhere would argue with me. It could be better, right? Doctors could talk to each other more. People wouldn't be saying, where are your records, and trying to figure out what your insurance covers. I mean, it's crazy what we put up with in healthcare. And so we're determined to transform care. And we want to do that. As Dr. Ahern and I said, we're going to go out in our careers, hopefully putting ourselves out of business and doing whatever we can for autoimmunity, for sure. So I want to put a thanks out to Highmark Health, which is our parent company, Alleghany Health Network, because over the years they have invested tens of millions of dollars into our vision for transforming care. So we're very fortunate to have a healthcare system that believes in us, and this is us over here. And as you know, we partnered with Highmark Insurance Company in 2013 and created this higher entity. But I really do have to say, not all healthcare systems focus on autoimmunity, right? They focus on cancer, they focus on cardiovascular disease, but who's doing anything for autoimmune disease? But AHN is, and we're very grateful to them for that. So let me go back. Hopefully this will stick here. So this is West Penn Hospital, and this is the hub of the new Autoimmunity Institute, and that's where you're sitting right now. But please know, our intent is not to just stay here. Our intent is for this to be the hub and have spokes out in all the regions so people don't have to travel. Because all I hear with patients coming in is the parking, the traffic, drives them crazy. So thank you all for making that trip. But our intention is really to get out into the communities and be able to provide care there as well. So this is the ribbon cutting, as we talked about, in May of 2018, and we are grateful to all of the people. This is our president and CEO of Alleghany Health Network, again, showing the commitment of the team. So this is what we mean by multidisciplinary team. So for my patients, you see this. I'm not telling you anything you don't know, but if you aren't a patient, you will appreciate this. This is the signage outside of our Autoimmunity Institute. And what we're showing you here is these are all the different specialties that practice here. And it's important to me because what I want is if you come to me and you've got a disease and you've got a skin rash, if you want, you don't have to, but if you want, you can see our dermatologist here that specializes in autoimmune skin disease. If you have kidney issues, you have the ability to stay here. And the beauty of being here under one roof is that there's definitely something to be said for practicing elbow to elbow with other physicians. Even if you're connected on the electronic health record, there's nothing like having them under the same roof. Believe me, it improves communication, for sure. This is how we started. And if you just look at the number of names on there, and then Dr. Ahern always likes to keep taking pictures because the names keep growing. Because what we're trying to do is bring more and more specialists into the Autoimmunity Institute. But we're very particular about who comes because we want people passionate about taking care of the disease. And I just have to point out, Dr. Aurora is in the back in her white coat. She's not a speaker today. She's a kidney specialist, works in our Autoimmunity Institute, was up seeing patients and came down to just pop in on the program. So that shows you the kind of commitment we have, and our patients love her, the ones with have kidney issues. Okay, so this is how you probably would say traditional healthcare is delivered, right? So there's the patient, that's you. Here's your provider, and I put provider because it could be a PA, physician's assistant, a nurse practitioner, or a physician. But normal healthcare is usually doctor, patient, and you may have your medical assistant and someone checking you in. And that's your team, primarily, right, on the outpatient. And we've said we got to blow this up, right? We need, because doctors can't do everything. And as a matter of fact, we don't do everything very well, to be honest with you. We need a team to manage patients. And this could be any specialist. So we said we need team-based care. So the first thing we want to add is a nurse navigator. Nurses are really critical in this model. And the nurse navigator is the person that catches you and helps you navigate. Right? You have this appointment, you're supposed to get that lab test, you need to get that. Who keeps track of all that? Sometimes you forget, right? I would say patients come, oh, I know you wanted me to get that test, Dr. Manzi. I didn't get that. And I don't find out until you come back. The nurse navigator keeps track of you and helps you navigate, tries to get you to where you need to be. We also added a pharmacist. I cannot tell you, Cassie is our new pharmacist. I don't know how I ever lived without her. She is so good. She helped you come in and you ask me questions about, can I take this medication with that one? And should I take it on an empty stomach? And is there an interaction with this? The truth is, I don't always have the answers to that. Cassie does, right? She's very, very good. She also helps with vaccinations, what are safe, what you should have. She's been absolutely invaluable to our team, and we think every practice should have this, to be honest. She also helps with prior authorizations and your insurance coverages and the help programs, et cetera. Our MAs are also very critical, and we've asked our MAs now, our medical assistants, they're the ones that check your blood pressure, get you in the room, the thing that you're used to doing. But now they have a really important role. They're going to be doing a lot of screening. They're screening now every patient for depression, anxiety, right? I need to know that before I come in the room, because if you've got a lot going on in your life, we want to help you address that. And no physician usually screens for that, but our MAs screen for that. They're now going to be screening for insurance issues and housing insecurity issues and whether you have food. Some people can't, it's a matter of, do they get their medications or do they eat? I mean, and we have patients that are making these decisions, and we need to know that so we can help you. We actually have relationships with the food bank, and we've got a healthy food center right here at West Penn for people that have food insecurity can actually get meals and nutrition from our healthy food center. So when we say we're caring for the patient, we're trying to think about more than just your disease. We also have added another indispensable person, and if any of you have interacted with her, Jenna Boswell, who's our behavioral health specialist. She does acute interventions for people that are struggling with depression and anxiety. Unbelievable addition. We have a social worker we're hiring that'll help you with any other issues you have, housing, etc. And then our research team is right there. They're there to enter you into our registries, tell you about new potential drug treatments. They're amazing, and they roam around with us. So this is our new model of care, which is very different. Our front desk is the first place you come in, and Joe showed this picture recently, and I love it because nothing is worse if you walk in a doctor's office and they act like, you know, they don't want to see you, right? They're behind their window. They don't look up. You're knocking, right? You've had that experience. I've had that experience. Not our team, right? So this is how they look every day. No, this is St. Patrick's Day. But Dr. A, I mean, we're all very committed, Jen Ferry, to say you need to walk in and feel good. From the time you walk in to the time you leave. We're always trying to get better. It's not always perfect, but we really do feel like your experience has to be a good one. This is our team. So grateful for this. This is, you'll recognize a Lisa, who, what's Lisa's last name? Sylvester, yes. It blocked my mind. Who did a TV spot one time on what we were doing here, and this is our wonderful team. And so this is just showing you, if you take a tour today, you'll see on the outside of where the patient exam rooms is something we call the huddle hall. And this is a new concept in management. I got to get rid of this thing. Put this away from it. But this is the huddle hall. It's this open space where physicians, nurses, behavioral health firms, we all sit together. We're not in an office with our doors closed. We feel like if we sit together without isolating each other, we're going to talk to each other. And we do. And the concept here is that at the beginning of the day, we look at all the patients that are coming in. We sit with our behavioral health specialist, with our nurse navigator, and we run the list of people that are coming in. And we say, oh, here's Mrs. Jones. You know, the last time she was here, she was having problems with this and this. We need our pharmacist to see her. And we start deciding on what care we want to provide for you that day. It's customized care. And that's really the model we're moving toward at the Institute. And this is just an example of Jenna. Jenna's my behavioral health specialist. If I walk in the room and someone's crying, and I'm trying to figure out what medications I want to give them, and they break down in tears because their daughter, something happened to their daughter, or this, a variety of different things. Look, life happens. The first thing I say is, you're too anxious today. Would you like to talk to somebody about this? 90% of the time they say yes. And I send Jenna in. She gets them hooked up with either a talk therapist or a counselor, or tries to help them at the moment. And it's a much better outcome for everybody. So we're very focused on you and what's happening in your life. So this is just showing you that since we launched in 2018, which isn't very long ago, these are all the states that patients have traveled from to come here, which just goes to show people are searching. They're hard to diagnose, these diseases. They're hard to treat, and people are looking for answers. And we want to be that place where people come. We even had patients from Alaska, and this patient wants to come back every 6 months with her, bringing other people with her, and Hawaii as well. So we believe what we're doing, there's a need, right? There's a gap. Otherwise, we wouldn't be seeing this. I have to give a shout out to Mike Lynn. He's sitting up front here. He's on the ARDA board, but Mike lives in Manhattan and has been the biggest cheerleader, waving our flag and trying to get the word out. Mike's sister has a very rare autoimmune disease, Nancy Lynn. It's called relapsing polychondritis, which is, if anybody's heard of it, but it's an autoimmune disease where the immune system targets the cartilage. So they get involved inflammation of the nose, the ears. But the serious part is that your wind tube has cartilage in it. And when it attacks the cartilage there, you can't breathe. And Nancy and Mike have been on a mission to raise awareness, and we're on that mission with them because it is an important autoimmune disease. And Mike hooked us up with Kyle Marcelli, who's a race car driver here, and we thought, what better way of getting our message out of what we're doing at AHN than slapping our logo on the side of a race car that travels all over the country racing. And so Joe and I have now become race car fans. I will save you the pictures, but we thought, and this was Joe's brilliant idea, that it would be autoimmunity racing, right? It's pretty cool. So this is where we're going, and I just want to point out this is a flyer that's going around the country because we keep trying to recruit the best of the best to come here, all the specialists to be a part of our team. So we are on a mission here. So thank you very much for your attention.
So we have time for a couple questions. Dr. Abdulbaki has a microphone that he will pass. You just put up your hand if you have a question. Wait for the...
I can repeat it. Yeah. So the question is, do we have plans for pediatrics?
To develop a pediatric unit.
Absolutely. And last year we actually we're very close to recruiting a pediatric rheumatologist. They're very few and far between. But that is absolutely next on the list. Yes. Yes, I can repeat your question if you're... Yeah, I understand exactly what you're asking. So I think, yes, so the question, it's a really good question. So the question is, do you get charged for the behavioral health person coming in because they're going to now put another bill in, right? And you may have a copay, or the pharmacist may bill and you're going to get a copay. The answer is no. And that was what we went to Highmark with. We said, we're not doing that because that's a barrier to health care. Because you're going to say, I don't want to see the behavioral health person. I'm not going to pay another copay. I'm not going to. So we said, absolutely not. That team works together and no one drops a bill. Now, the specialists do. Like if you have see a nephrologist or another physician specialist, but not the team. We huddled together. Yes. Yes, and as a matter of fact, we have, and we've been doing this in a few other areas, but we have what we call multidisciplinary notes. So, you'll see what the pharmacist did, you'll see what other people did within the record. Yes. Yes.
When I saw the list of people who have different disorders, is there, like I have several that I saw on the list, would you attack just one of those and hope that it would mitigate the other disorders?
Well, that's a really good question. It depends on what they are. Because as Virginia said, and it's really true, and it's exciting actually, but the same treatments that people are using to treat psoriasis, for example, inflammatory bowel disease, also are effective for rheumatoid arthritis. So there are treatments that cross, right, different autoimmune diseases. Some do not. Autoimmune thyroid you treat with thyroid medicine. That's very different than what you would treat your rheumatoid arthritis or lupus with. So it depends, is the answer. But I will say, if we solve the mystery of one disease, it will clearly impact other autoimmune diseases because they share these same genetics, they share the same, mechanisms, if you will. Somebody had a question? Yes. Okay, so Yeah, no, I think it's a big issue. So first of all, I love when you challenge. Okay, so the question is, why don't we have physical therapy or rehabilitation as a part of the team? First of all, the best thing any of you can do is be constructively critical of what we're doing and help us make it better. Really, so I appreciate you bringing that up. I could not agree more. I think physical therapy, occupational therapy, we refer a lot to them. So it's a matter of one step and one phase at a time. I think what we'll develop and what we're starting to do now is develop partners. They may not necessarily be housed here, but they would be a partner with us where we would be able to refer you to people that understand autoimmunity and manage you better. So it's a very good point. Yes. So the question is about immunotherapy for cancer. So first of all, when I talk about sophisticated audience, you're a sophisticated audience. That's a really good question. So the question is, there are these new breakthrough treatments for cancer. And when I say breakthrough, they are curing cancers that were never curable before. Melanoma, metastatic breast cancer, they're amazing. But what these treatments do is instead of chemotherapy, right, which goes in and just kind of kills everything, these therapies train your immune system to fight the cancer. That's what these immune therapies do. So can you imagine that? So it's kind of like a foreign army going in and fighting as opposed to training the local army to fight. So these therapies are great. The problem is we're seeing more autoimmune diseases happening with those treatments because you can imagine they're going in, they're revving up that immune system to fight the cancer, and if they can't distinguish cancer from self, you can develop autoimmunity. So the answer is yes, we're seeing more autoimmune diseases with those therapies. However, we've been able to treat and manage them. And as I tell my patients, if you're a lupus patient and you develop metastatic breast cancer, get the immune therapy, because the most important thing is to treat the cancer. We'll manage your lupus. But that's a great question.
So Dr. Manzi and all the speakers will be available during lunch. We're going to try to stay on track here. And I knew I was going to miss some team members as they came in, but I want to also recognize Glennis, who's one of our study coordinators. And I hope I haven't missed anyone else. Anyway, I want to tell you a quick story about our team, many of whom are here, but you heard about and you saw the front desk. So Fran and Brittany are the best, and I love giving tours, and we'll be giving tours later. But this week, I gave several tours, and I always like to tell those who are touring that we are all about hospitality. We're modeling ourselves after the hospitality industry, and these are the first faces, the first voices our patients see and hear. And so we actually went to the Four Seasons. Sometimes I say Four Seasons, sometimes I say Disney or Ritz-Carlton. I said, and we recruited them away. And they're like, really? I said, no, they're actually better. They're better than they are. And so they really are. Okay, so moving right along. So you've heard from Dr. Manzi, you may know otherwise, autoimmune diseases tend to affect women more often than men. So 9 out of 10 lupus patients are women. 98 out of 100 patients with autoimmune thyroid disease are women. So there's a particular challenges. Well, fortunately, we have a world's expert and highly popular author on the topic of women and autoimmune disease. So Rita Baron-Faust has a family history of autoimmune disease, and she's been a national educator of ARDA throughout the country for many years. She's adjunct professor at St. Francis College, and she's author of The Autoimmune Connection, Essential Information for Women on Diagnosis, Treatment, and Getting On with Your Life. So as you'll hear, Rita hopes through her book and through her speaking, patients will get a sense of empowerment and knowledge that'll help them take charge of their own health care, advocate for themselves, and not get lost in the system, as you've heard can often happen. So please welcome Rita.
It's a real thrill to be here because we've been talking about this at ARDA for as long as I've been working with them. And to actually be in an autoimmunity center, is thrilling, beyond belief. I come to this as a medical journalist for 25 years. I wrote about every aspect of medicine. And I do have a family history of autoimmune disease, and I'm grateful for Dr. Manzi explaining autoimmunity. Now I don't have to. Okay, do you have more than one autoimmune disease? Raise your hands. I like to say autoimmunity, collect them all. Have you ever had your symptoms regarded as female complaints? All right, a few hands go up. That's not a question for the men. Did you spend years trying to get an accurate diagnosis? It could be due to missed connections. Autoimmune disease cluster, often with overlapping symptoms. So if you have 3 diseases and all of them cause joint pain, all of them cause depression or inflammation, you can't sort that out easily. Non-specific symptoms, they can come and go. You could go see your rheumatologist one day and your joints are not red and swollen. You come back the next week and they say, oh my God, you have rheumatoid arthritis. It's almost an invisible disease unless you have some outward sign. And thankfully, increased awareness and understanding of autoimmunity is now becoming more prevalent. So I don't need to go through this explanation of autoimmunity, but when Dr. Manzi talked about environmental exposures, it's much more than sun and smoking. It's viruses, it's pollutants, it's food, it's multifactorial. So if it's environmental, it's not in your body. And that's about half your risk, believe it or not. Environmental exposures affect the function of genes. And they affect the function of the genes that signal the B cells and the T cells to go on the attack. Autoimmunity causes more than 140 diseases and affects more than 50 million Americans, and we think that's a small estimate. But here's that same slide again with the different parts of your body. 75% of people with autoimmune diseases are women, affected often during their reproductive years. It affects your ability to have children. It affects your whole reproductive system, and you're going, wait, if it affects my joints, what's that got to do with my uterus? It does, because you can't disconnect all the hormones and cells that are communicating with each other. And they can affect any part of the body, often multiple parts. So some symptoms can be dismissed as female complaints. If you're seeing a non-specialist, you can have vaginal yeast infections in type 1 diabetes. That may be the only thing that's happening that's visible to you, that's apparent to you. Incontinence in multiple sclerosis because it affects the nerves. Night sweats in Crohn's disease. Somebody's likely to tell you, oh, you're going into menopause. That's your gut. What's that got to do with night sweats? GI upsets, diarrhea, and Crohn's disease. My dad had Crohn's, he had thyroid disease, foot pain, and autoimmune or arthritis. And here's a picture of Louboutin shoes. And one of the first people I interviewed for my book, 15 years ago, was the actress Kathleen Turner. She had foot pain, and often that's the first thing that happens in rheumatoid arthritis. And the first thing the doctor said was, honey, you got to get rid of those shoes. He was, in fact, blaming her for her own pain. Dry eyes, dry mouth, dry vagina, and Sjogren's syndrome. Again, those are symptoms typically associated with menopausal women, and I'm still waiting for my diagnosis of Sjogren's. These are the statistics that Virginia quoted, but half of women have been told it's in your head. You're a complainer. You're overly concerned. And the time that it takes to get diagnosed can depend on your disease. But it's still a little over 4 years. Women were told their symptoms were imagined. If I have dry mouth, somebody says, well, suck on hard candy. Lupus. There are symptoms that don't seem to have an immediate cure, and medicine that isn't holistic is focused on treating a specific problem, the one that's easily spotted or diagnosed. And delayed diagnosis can lead to death or disability. Not so much today, but it still happens. Between 2000 and 2015, lupus was the 10th leading cause of death among women ages 15 to 24, and 14th after that. So that's pretty serious. Here's the female to male ratios. Hashimoto's, thyroid disease. Walk down the streets of Pittsburgh, tap a woman in front of you on the shoulder and say, pardon me, do you have a thyroid problem? Chances are she'd say, why, yes. How did you know? Because it's that common. Lupus, Sjogren's. See the list? It skews heavily toward women. Now, some autoimmune diseases are an equal opportunity destroyer, but most of them target women disproportionately, and women of color. Why are we more at risk? We have stronger immune systems. We have more autoantibodies. We have specific molecular on-off switches that are just being researched. A lot of what I'm telling you is in the process of being researched. Medicine always has more questions than there are answers. We have 2 X chromosomes. That can influence your disease. Men have an XY. For men with an autoimmune disease, it's often more serious because of their Y chromosome. There are diseases that are called X-linked because they have more to do with having 2 X chromosomes. Female hormones, that's a biggie, and for as long as I've been writing and researching autoimmune disease, that's been the big question. How much do hormones affect it? We just don't know, because your hormones are all over. You can't, take your head off, drop it off at the doctor and say, can you fix my headache and pick it up later in the day? It doesn't happen. Fetal cells from past pregnancies. This is fascinating. Extra sensitivity to environmental factors, not just sun. Chemicals in the atmosphere, chemicals in the water. A lot of women have atopic dermatitis. We're sensitive to things. We wear makeup. We wear skin lotion. It affects our skin. Stress and anxiety disorders are more common. So, okay, what do female hormones do? Estrogen may stimulate your immune system. RA gets better in pregnancy. What's that about? You're not taking medication. Your hormones are helping you out. But then later on, they're not. High levels in pregnancy may trigger remission. Low levels in menopause may worsen rheumatoid arthritis. People are not prepared for that, and they're not told about that. And that's what holistic care is about. Looking at your life stage, where you are, your mental state, it's more than just physical symptoms. Progesterone, that's the hormone of PMS. Women who take progesterone, it's like PMS in a bottle. But high levels can worsen multiple sclerosis. and myasthenia gravis. And this is something that your doctor may not know about if they're not a specialist. Androgens. Women have male hormones. Not the same set as guys do. Men have estrogen too. But androgens can act as immune suppressors. Low testosterone may underlie lupus. You're going, low testosterone? That's one of the theories that has been talked about. Prolactin, that's the hormone relating to breastfeeding. It's elevated in lupus and other autoimmune diseases. And this is something women don't really know about. And a lot of physicians don't know about. And I'm so happy that this institution is going to be educating people. Whoops. You're wondering, what has a past pregnancy got to do with it? Well, think about it. A woman is hosting another being in her body that has half the genes of her husband and half of hers. That makes it a chimera. You know, that famous mythological animal that's got the head of one and the tail of the other? Well, if your immune system is attacking aliens, why isn't it attacking the baby? It's in a privileged space. The immune system calls off its attack. But those fetal cells, it's a two-way street through the placenta. And those fetal cells can hang around for 20 years, possibly triggering autoimmune disease. You've got a cell that's half your genes, half somebody else's. What does the immune system know what to attack? And that's seen, at least we know so far, in scleroderma, Sjogren's, thyroid disease, autoimmune liver. Autoimmunity is not simple. And that's why it takes a long time to be diagnosed. X chromosomes, linked to higher antibody levels, autoantibody levels, stronger immune responses. So you ladies know when your husband gets a cold, it seems to hang around forever. Your cold is over in a couple of days sometimes. Why is that? You have a stronger immune system. The X chromosome dosage, we've got 2, men have 1. And having 2 X chromosomes can promote T-cell proliferation, multiplying. And that can affect disease severity if the disease is driven by destructive T cells. Activation of X-linked genes may affect adaptive immunity and inflammation. So this is we're complicated animals, human beings. So they cluster in families. I have my students at St. Francis fill out a genetic chart like this in all of my health classes and say, ask questions now. Your mother may have rheumatoid arthritis, your sister may have Crohn's, but it's all part of the same disease category. My dad had Crohn's, he had a goiter, I probably have Sjogren's, I have thyroid disease, and I can tell you that these are not simple problems. But you have to be aware if you come from a family with autoimmune disease. I didn't know till I started writing that book and asking questions. So what are the 3 most common symptoms? They are also more common in women. Fatigue. We're not talking about being tired. I had my first attack of fatigue last week, and I can tell you, it's not like being sleepy. Joint pain. Your joints ache. That's nonspecific. Fatigue is nonspecific. Depression. That is the most common symptom of multiple sclerosis before any disease is diagnosed. And it's not surprising. MS affects the brain. Fatigue, it's seen in RA, thyroid disease, look at the list. And fatigue is crippling. You feel like your feet are stuck in cement and you cannot take one more step. No matter what you're telling yourself, I have to do this, I have to do that, you can't move. Joint pain. Well, okay, rheumatoid arthritis, that affects your joints. And yes, lupus affects your joints. But inflammatory bowel disease? That's my gut. Why is that affecting my joints? Because this is most of these things are body-wide effects. Celiac disease, why would that affect my joints if I can't eat bread? Because it's your intestines, your digestive system is central to your health. Depression, seen in RA, and you'll hear about depression and anxiety later. But it's often the first symptom of MS and Hashimoto's. An underactive thyroid, one of the common symptoms is depression. Besides feeling cold, you are depressed. And there was a study just, I guess, last year that linked depression to an increased risk of lupus. Twice as common in women. Depression is twice as common in women than men. So we're talking about a complex human being walking into a doctor's office and needing a whole host of symptoms and problems addressed, not just pain. So we need to know about the diseases that cluster with thyroid disease, because you can't just blame what you're experiencing on the particular disease you have. So look at this list. I didn't know my grandmother had pernicious anemia. I didn't even know what it was when I started writing this book. And all of these diseases, and this is why I was compelled to write a book. Special concerns for women, delayed puberty. Years ago, when I was first told there was something wrong with my thyroid, nobody looked at anything but the thyroid. And there were all kinds of signs, but nobody knew that, and nobody knew the word autoimmunity. Postpartum thyroid disease. You have a baby. You figure, oh, well, postpartum blues, that happens. Postpartum thyroid disease? It happens. Infertility, heavier periods. These are female problems that most women do not associate with autoimmune disease. Graves' disease. Anxiety. When your thyroid's overactive, you are supercharged. You're anxious. Mood swings, mania. If you have crazy mood swings, what's somebody going to tell you? Oh, well, maybe you have bipolar depression. They're missing the big picture. They won't be missing the big picture here. So rheumatoid arthritis clusters with Sjogren's, Raynaud's, anybody here where your hands turn white and cold? It's scary when you first see it. The first time I took off my gloves in the winter and saw that, I was, oh my God. I thought it was very normal for people to get white feet when they went ice skating. I didn't know that was a problem. Thyroid disease, psoriatic arthritis, there's always a cluster. And if you don't know about them, you're going to blame anything you're experiencing on the particular disease you've been diagnosed with, and it's going to be a puzzlement to the physicians who see you. Special concerns for women, reduced fertility, premature ovarian failure. Your ovaries just stop working, and you're nowhere near menopause. Increased risk of cardiovascular disease. Now, that is seen in just about all autoimmune diseases. Why? Inflammation. Inflammation causes havoc in the body, and it affects the heart and blood vessels. Increased risk of osteoporosis. In celiac, you may not be absorbing nutrients you need to keep your bones healthy, but you may be taking medication for your autoimmune disease that causes bone loss. And you have to be put on drugs that will keep your bones healthy. Lupus clusters with thyroid. When you look at this, it's startling. You go, how could I have all of those diseases? You could have little pieces of them. Special concerns for women. What's at the top? Missed menstrual periods, miscarriage, high-risk pregnancy, high blood pressure in pregnancy, eclampsia, disease flares during pregnancy. My co-author, that's her specialty in research, is pregnancy and lupus. Because there's so many mysterious things going on. She's a world expert in this. Neonatal lupus, that's her specialty. Earlier menopause. A woman with autoimmune disease can go into menopause 2 to 5 years earlier. More common and severe in African American women. Sjogren's. Here are the diseases that cluster with dry eyes and dry mouth. If you have Sjogren's and you're having other symptoms, it could be any one of these things, which is why you need a center that will look at you holistically as a whole person. What else could be going on here? Special concerns for women in Sjogren's, not just dry eyes, chronic dry mouth. Why is that a problem? The saliva is the self-cleaning mechanism in your mouth. Without that, you get cavities. Burning mouth syndrome. Has anybody here experienced burning mouth syndrome? That's part of Sjogren's too. Not in everybody, but it can be an early sign of it. Dry vagina, confused with menopausal atrophy. So if that's your main symptom, I've got dry eyes and dry vagina, what is my physician going to tell me? It's menopause. You're just going through it earlier. Fatigue. You need a good night's sleep. So that's why you have to be an advocate for yourself. This symptom is real and it doesn't have anything to... I sleep really well. This symptom, I'm fatigued not because I don't sleep. I'm fatigued because of something else. It may be my disease. Scleroderma, the hard skin disease, clusters with these other diseases. And this is why women need to know about this. It clusters with lupus. And lupus is the great pretender. It can act like a lot of other autoimmune diseases. Again, what are the concerns in lupus? Reproductive problems, missed periods, infertility. I don't think fibroids have to do with autoimmunity, but I don't know. Premature birth, low birth weight babies, because this affects your connective tissues. What's growing in the belly, the connective tissues are forming. So that could affect the baby. And if you don't know you have that disease or an autoimmunity problem, you can have a low birth weight baby. Dry vagina and painful sex. When I first started writing about this stuff 25 years ago, that was just being researched. I found one journal report about that. So imagine you're a woman with scleroderma and you're having painful sex and your doctor is like, that's so common. Don't worry about it. Find a lube. So there's a whole host of problems that don't seem like a disease, but they are all important. Inflammatory bowel disease, chronic diarrhea, abdominal pain, low-grade fever. These are non-specific. I have a stomach ache. Well, maybe you ate something that was spoiled. Maybe you ate something that was, that had some bacteria in it. Maybe you didn't. All of these symptoms, night sweats, unexplained weight loss. Some women would say, oh, I'll take that. Well, no, you really wouldn't, because that means you're not absorbing valuable nutrients. And joint pain, clubbed fingernails, things you would never associate with your gut. Crohn's disease clusters, thyroid disease, ankylosing spondylitis. Irritable bowel syndrome is not Crohn's disease. One has the initials IBD, one has the initials IBS. IBS is related to anxiety. They've called it nervous gut. But if you have an autoimmune disease and you're anxious and you have Crohn's, maybe you're going to have symptoms of irritable bowel. So you really have to be looked at. The whole person has to be looked at. IBD special concerns, again, what are they? Delayed puberty, night sweats, genital ulcerations, and this is not a pleasant thing. Bone loss due to malabsorption or to corticosteroid drugs. How many of you are on corticosteroids? Have you been told it may lead to bone loss? Because if you haven't been, this is important. Celiac clusters with type 1 diabetes and other diseases. Special concerns for women, all of these things. Multiple sclerosis clusters with these diseases. You almost need a card to carry around with you saying, okay, I have RA, what else could I have? And you need to bring it to your doctor. Come on, pick one. But there's good news. There may be potential predictive autoantibodies that you could get a blood test for. Right now, there are very few conclusive tests for autoimmune diseases. It's not like, oh, you have high blood pressure, you went over this number. It's not simple. But we're getting to the point where you may have, before you even get symptoms, you may have those autoantibodies circulating in your body. And if that's detected, could be a red flag that people would miss. More genes are being connected. Maybe there's a way to prevent autoimmunity. You know, like with peanut allergies, don't give the child peanuts. Well, in celiac, babies eat cereal. So if you didn't know that there was celiac disease in your family, or you would be told, oh, well, children outgrow that. I had a cousin with 3 autoimmune diseases who had celiac disease, and when she was in her 40s, she was told, you should have outgrown this by now. And there are better therapies targeting specific autoantibodies that can treat several autoimmune diseases. It's the dose, it's the target, it's how it's given. So I'm not a doctor, I don't even play one on TV. ARDA is probably the best source. And now we have this place, which is, I'm sorry I won't be able to take the tour because it's been my dream too. And that's the cover of the book. I hate to say this, but sometimes these things are outdated by the time you finish spell checking. But a lot of the basics in here of how therapies work. This is the 2nd edition. Came out 3 years ago. I'm hoping to convince the publisher for a 3rd. Thank you so much.
So that was outstanding. We have time for maybe 1 or 2 questions. Please. So the question relates to stress.
Well, when you're stressed, your body is releasing stress hormones, adrenaline, cortisol. Well, these also affect symptoms in autoimmune disease. When you're stressed, Carnegie Mellon has been doing research for 20 years into how stress can depress the immune system and make you more likely to get a cold. It has everything to do with it.
So I think we have two more expert speakers before lunch, but I think Dr. Manzi, always thinking about patients in care, suggests we take a really quick 5-minute stretch break. But please, 5 minutes so we stay on track, because then there will be lunch break. Okay, 5 minutes. Well, that was terrific.
Thank you.
Fine, we're like this with Jill. Yeah, Bob Clancy and Jill are they've been here as guest speakers. Yeah. Wow. And if you could call those in from the lobby. Okay, welcome back. Everyone, please take your seats. So I've been asked where and when and how the proceedings will be available. So the entire program is being video recorded, and at some point it will be uploaded to our website and most likely be available otherwise. So please check in with ARDA, check in with the AHN Autoimmunity Institute. Our contact information for both organizations is out of the desk, and we will keep you posted on when this will be available. Just let the last few folks. Dr. Manzi, can you just let those in the lobby know we're starting this? I see there's still a crowd coming through. Big line at the restroom. Okay, we will begin. So you heard from Dr. Manzi about Jenna Boswell, our behavioral health expert, and the emotional behavioral health issues that are so common in our patients with autoimmune disease. And traditionally what would happen is a patient would see their provider, say their rheumatologist, for their primary autoimmune disease, and their anxiety, their depression, their fatigue would likely not be addressed, even asked about. And the physician or the provider would hope to treat the primary disease and hope all the rest goes away. Well, as you know, more often than not, it doesn't. So we are thrilled to have not only Jenna Boswell, our behavioral health expert, but also a world's expert psychiatrist who specializes in anxiety and depressive disorders. So we're going to hear now from Dr. Alicia Kaplan. She's a graduate of Chicago Medical School at Rosalind Franklin University. She completed her training as a resident and fellow Mount Sinai in New York. And she has been an expert consultant for the United States Department of Health and Human Services Office on Women's Health. And we're thrilled that she is our psychiatrist expert in the AHN Autoimmune Institute. We're thrilled to have her here this morning to speak with you. So, Dr. Kaplan.
Good morning, everyone. Can you all hear me? Good, okay. So I'm going to start with saying that I'm very happy to be here today. I have been very fortunate because throughout my career at Alleghany Health Network, I have been pretty much along with medical disease in the sense that I was part of the gastroenterology department for about 12 years, part of the GI team before I moved over to autoimmunity. So I want to thank Dr. Manzi and Dr. Lebovitz for that. So that's kind of where I'm coming from my perspective. So this is what I do every day, okay? I'm going to be focusing using the model of inflammatory bowel disease, coming from my experience with GI. But if people have any specific questions afterward, they can certainly ask me, and there will be a lot of overlap, as we'll see in discussing this. So it's important to know that patients with inflammatory bowel disease, Crohn's and ulcerative colitis, have about twice the risk of that in the general population of having anxiety and depression. So that's pretty significant, and that can be seen along with all the chronic medical illnesses. And not only that, there's a difference between having an anxiety or depressive disorder and having symptoms. So patients may not have a full disorder, yet they really feel the emotional distress from the symptoms, and especially during flares, and I'll be discussing that a little bit as well. So it's been shown that if patients with IBD have anxiety and depression, this can be a real problem if it's left untreated, because this can lead to more severe IBD symptoms, more frequent flares, increased rates of hospitalization, and less medication compliance than patients that don't have anxiety and depression along with IBD. So this really takes a toll on patients, and that's why it's very important to gain understanding and understand treatments, not only for the patient, but for the family members and loved ones. And of course, you know, what we're really looking at is quality of life. So we can do different rating scales of anxiety and depression, and we can talk about symptoms, but really what we're looking for is improvements in patients' functional standing and their quality of life. When patients are in a flare of IBD, they tell me that their anxiety gets much worse as well as their mood, okay? And that makes a lot of sense because of the significant change in their life, right? The significant adjustment. Some people are younger than others versus some people are in their childbearing years or an active working lifestyle. So this really hits a toll. And that's really what I see along with autoimmunity, what people tell me, that the flares are very affecting their life and their quality of life. So it makes sense that, and a lot of what I do in my job is looking at patients and their different levels of stress, right? So when stress affects the mind, it's considered psychological distress. And patients can, as human beings, we can often deal with a lot acutely. For example, when we really have a sign of danger out there, our body is adaptive for survival. So that when we're anxious, when we feel nervous or stressed, it's normal for our heart to go fast, us to start breathing heavily. We may feel a little bit lightheaded or dizzy, or our stomach may bother us a little bit, because when stress starts out, it's in a survival mode. We all want to have it as human beings. But what happens is when it takes a toll and it becomes chronic, as it often does in autoimmunity disease, then it may turn into psychological heightening distress, which may become, in my world, an anxiety or a depressive disorder. So sometimes that relationship is a little bit unclear. It appears to be bidirectional, and that stress is associated with the flares, but having IBD can cause stress, so it's that overlap. So when I'm seeing a particular patient over at the Autoimmunity Institute, I'm really looking at the individual patient. And I guess that's kind of like the key that I want everyone to understand. So everybody's course in life, every human being is different. But there are certain themes that remain the same that can make us feel distressed. So there's a term called uncertainty, right? Unpredictability of the disease process. And as human beings, we want as much control as we can have. And those of us that have anxiety disorders, it tends to be even worse. And not only that, but the unpredictability of a flare. When is it going to come, right? And so what I've noticed with my patients is this anticipatory component where, you know, they might have done well for a year. They might have done well for 5 years. But then there's always that fear in the back of the mind. And especially when they start getting symptoms, or even if they tell me that sometimes this is where it's unique to the patient experience. If someone's having some depressive symptoms, they may say, this is how I know it's coming. Or it's my fatigue level, I know it's coming. So sometimes that's taken me years to work with patients in identifying that. But if you think about it, that anticipatory fear may be more heightened in the autoimmune disease population than anywhere else, because it's the fear of the body. So when we're under stress and we're out in our community, it's more helpful if we can say, gosh, I'm really worried about getting on that train, or, you know, it's late at night. Should I be walking by myself? Or I know I'm worrying about this test. But when it's the body, when it's the inside, that's even more heightened. And that's kind of the crux of what we call panic disorder, but it's different when it's the actual body, because that's the fear, okay? But it can look very similar and be just as impairing. So these are some of the changes, these significant changes that I know all of you know about, but I'm just telling you that I understand. And it also helps with explaining to other people that may not understand that fear of loss of control of the bowel, social isolation. All of a sudden we went from being very independent, and now we have to depend on people. And whether that's for transportation or for child raising or even getting our medication, it can be hard sometimes to even ask for help, especially if we've been dealing with this disease all these years and we tend to be very self-reliant in changing that role and having to rely on people. Of course, body image changes, fear of surgery, that uncertainty, and even fear of cancer. And some people don't want to talk about it with their family even, because they want to have a strong front and don't want to let their family know that they're worrying. So these are all things that people have told me, and makes me understand their anxiety symptoms and depressive symptoms that may or may not become a disorder. Fatigue is very common, as you know, and it's associated with poor quality of life, anxiety, and depression. And patients tell me that the fatigue is like no other, so it can be at different times. And it does overlap with the diagnosis of depression. And that can make it a confound, and that can sometimes make it difficult to diagnose. But I'm going to talk a little bit about now what I'm calling a major depressive episode. And this is from what we call the DSM-5. And in order to make a diagnosis of depression, clinical depression, so that's different than having, a week where we're feeling bad or having a sad mood or some changes in sleep. But to actually have a diagnosis of a major depressive episode, we have to have, for a 2-week period, either depressed mood most of the day, every day, or loss of interest or pleasure in most or all activities. So some patients will come to me, and I've seen this before, certainly, presenting with depression. And it's like, it's hit them like a virus, okay? It's like a virus. That's the best way to describe it. They can't think right. They're not sleeping, or they're sleeping too much. They're very slowed down. If I was once bubbly, then I'm more slowed. And again, and that's something that loved ones can see in the person that someone may not be able to see themselves. So I teach the residents this, the psychiatry residents and medical students, that you don't have to say you're depressed to have a depressive episode. It can just be a loss of interest or pleasure in most of or all activities. So that's where sometimes patients can't see it in themselves, that they're actually, that they can say, I'm sad most of the time. And then that's associated with at least 3 or 4 other symptoms, like change in sleep, weight loss, weight gain. These are what we call neurovegetative signs of depression, slowing down or too revved up that's observed by others. Not to make things more complicated, but sometimes the time of the year, I'm always like checking out what time of year they do better, do worse. Some people it's season neutral, okay, but some people in the winter, they get more slowed down, like a hibernation mode. Whereas there's like 20 to 30% of patients with seasonal depression that get revved up in the summer. And I see every summer they get clinically depressed. So they're anxious, they're uppity. So that's important for me to know as well. Okay, energy is a big one. That's where it overlaps with IBD. And decreased ability to concentrate, think, or make decisions. So as I said already, that can, impact people getting care if they're in a clinical depression and they can't think through it. That's where it's very important to have social support, family, loved ones, good friends. And I've had that happen before, where patients will bring in a very close confidant to help with that period of time. Because if you're feeling that bad and you can't think through it, then how can we expect you, to be able to go through your important treatments and being on time and being organized with that? Of course, these are more serious symptoms, and we don't take these lightly. Thoughts of suicide, hopelessness, worthlessness. And that's where seeing a mental health professional is very important, and we do have crisis numbers. So it's very hard when someone's feeling that bad to see through it, and they need somebody at their side. Okay. So that's a little bit about clinical depression and how it overlaps with chronic medical disease, such as IBD. Anxiety, on the other hand, is feelings of worry, nervousness, or fear about an event or situation. And like we said before, it's part of the body's fight or flight response, which prepares us to act quickly in the face of danger. But what happens in modern day society is that we often don't have those acute dangers that our ancestors did when they were out in the wild and they had to fight for food. But our body is the same and our brain is the same. So it's more modern day stress that can put us quickly into that fight or flight mode. And I'm going to be talking a little bit about anxiety and how that can overlap. And when we call something a disorder, it has to significantly interfere with our functioning and cause distress. This is from the Anxiety and Depression Association of America. It used to be called the Anxiety Disorders Association of America, but it's a very good resource, and I'm a member and provider for that, and I've been to that meeting multiple times. This is kind of like my life. And so I encourage you, if you have any interest, to look at that website. It's very informational. I want to point out that with anxiety, and this has been a lot of my interest as well, is when we have that fight or flight response, it can affect all different parts of the body, okay? So some of us, you know, when we get under stress and we get anxious, it goes right to our stomach, you know? And we call that gut responders. So a lot of us can identify with that, because what happens is when we're under stress, our body really doesn't care about our stomach. Like it's trying to lighten the load, or, you know, we're not trying to eat because we're trying to survive, right? Our survivors are our initial, you know, people. So, but we can also get symptoms of increased heart rate, shortness of breath, numbness, tingling, dizziness, choking. And some of my patients tell me they have more symptoms than others. I have some patients that tell me when they're under stress and anxious, they just feel a feeling of choking. Some people have more, they're really distressed by their heart rate or dizziness or lightheadedness or their stomach. So that's a teaching point as well, that anxiety hits us all in different ways. But again, initially it is for survival reasons, but when it takes its toll and it goes overboard, then it's really can be disabling, almost like, you know, a false smoke alarm that goes off over and over again when there really isn't a fire. But we get tricked, and our body and our mind believes that there's an emergency, and that's how these symptoms can really intensify themselves. Okay. So in talking about a holistic approach in treating anxiety and depression, it's important to look at patients and understand the teaching of what we call biopsychosocial model of medicine. So we're treating the whole person. We're treating the patient's mind and the body together. They are not separated. And I'm educating you a little bit about those components today. And I've had other patients of mine teach other people about it, because once you understand it a little better, it can be very enlightening, and it can spread. So I'll be talking a little bit about cognitive behavioral therapy, and I'll be talking a little bit about some of the treatments we do here, and a little bit about medication when it's needed. So this is a diagram that I write a lot in my office on my whiteboard. So you can kind of, every time I wipe it off, you can see it there a little bit, okay? And I repeat myself over and over again, but this is what I tell my patients. So in order to keep anxiety alive, there have to be 3 parts. There's the thoughts, the physical symptoms, and behavior, okay? And these all feed on each other. So, and what I'm talking about, thoughts are, we all have thoughts all day long. You know, how did you get here today? Who did you have to pick up? You got dressed, you brushed your teeth. You got in the car, you turned to left, you turned to right, you sped up, you parked, all these things. I had to call my grandma, I had to check my email, right? These are called thoughts as human beings. When we have anxiety, okay, when we've been traumatized by a health experience, our mind starts going into survival mode, and we have automatic thoughts that become colored with fear. And what I mean by that is when we have anxiety, when we tend to worry about our health, we have what we call what-if thoughts, and our mind tends to overestimate the probability of something bad happening in the future related to our health. And we also underestimate our ability to cope. These are called thoughts that are highly involved in anxiety. And in addition to that, we get physical symptoms like I talked about before, and some people have more GI symptoms, some people have more rapid heart rate, And some people have a flat-out panic attack where it comes out of nowhere and it has to have at least 5 of those symptoms. Patients with panic disorder fear their physical symptoms that they are going to, from the panic attack, they're going to have a heart attack or a stroke, or they're going to go crazy. And the behaviors that are involved in anxiety are either avoidance, which is a big one, or restlessness, irritability, reassurance checking, compulsions. So some patients with anxiety that's related to the GI tract may find, and again, it's all due for survival mode. You know, knowing where the bathrooms are, knowing where the closest hospital is if I should travel, having someone go with me in the car, having a bag of a water or some other things in case I go into a flare or an accident. And again, these are all used for survival, but what can happen is when these go haywire, so to speak, they become our life and the world becomes much smaller. So the illness is there, the IBD is there, but it's taken its toll and it's starting to affect our functioning. So what I tell my patients is, an area here that's a problem can spread into these other areas. But at the same time, an improvement in one of these areas can improve other areas. So I'm just going to go over an example of one person and what they may be feeling, okay? So this particular, and this is taken from Melissa Hunt, Dr. Hunt, who's a big cognitive behavioral therapist at Penn, who's written books, and I've met her on several occasions at the ADAA. So a patient may have an initial gut sensation, whether it's nausea or diarrhea. And then they may have these thoughts which say, oh no, there it goes again. This is awful. I can't stand it. I'll have to leave. Everyone will think there's something wrong with me. And then that might heighten feelings like feeling anxious about pain, feeling upset, frustrated, or embarrassed. And those feelings can set off the fight or flight response, where all of a sudden, because we're feeling that bad, our body is in touch with our mind, right? That, oh God, this is really bad. And again, this is not taking away from the disease at all, but I'm just telling you some of the overlap that can occur, where patients might feel increased heart rate, breathing heavy, sweating, increased GI distress, and then that process feeds some of those symptoms again that are naturally going on, and then it can become what we call a vicious circle, okay? Or vicious cycle. You might have heard that before. Now, the reason that some of those arrows are there is because, see right here, this can be an area where patients can start looking at their body and working on what we call relaxation strategies. And some of the other providers today may be talking about this, but this is kind of the holistic approach in that we say that in a very, in a relaxed body, it's harder to have an anxious mind. So we teach the patients how to do abdominal breathing instead of breathing up here. When we tend to feel anxious, we tend to hyperventilate, we breathe faster, and breathing up here can create more muscle tension, which is part of the generalized anxiety disorder diagnosis. And it can feed symptoms that are similar to panic attacks sometimes. Some patients tell me they get numbness or tingling in their hands or numbness around their mouth or increased heart rate. So learning to breathe with their abdomen can be very positive. And that's where techniques such as yoga or even learning this method, I'll be talking in a minute about something that I do with my patients called Free Spira, which is really targeting panic. But I want you to understand that now some patients like the breathing, some people like what we call progressive muscle relaxation, which is learning to tighten and relax the muscles in your body. And some people like imagery, which can be very important. and doing meditations. But those are 3 ways that can, what we call, maximize our parasympathetic nervous system and bring down our sympathetic nervous system tone, which is part of our fight or flight response. So interacting here can be very helpful to stop this cycle. And interacting here is what we do with cognitive therapy. There's a book I really like called Mind Over Mood, which is a self-help book, but it teaches the person how to look at their thoughts like a scientist and look for the ways we think. And I spent a whole week at Cape Cod at a psychological CBT therapy conference about 6 years ago, and I was the only psychiatrist there. Most of the people there were therapists, or, psychologists and social workers. And I went up in the intermission and I said, "Oh, I need help. I really want to learn this, And the Jonathan Abramovitz, who's like it in the United States for anxiety, he's like, "Get Mind Over Mood," and he wrote it down for me. So since then, I've been telling everybody about it, primary care doctors, and my patients and other PCPs in the community, because something like that is only very helpful to start seeing the way we think. We can't expect to have changes before we identify how we're thinking. Okay. And then, of course, the behavioral therapy is right there too, and looking ways to gently expose ourselves to the situations that we fear. Since I am a psychiatrist and I specialize in anxiety and depression, and especially the gut, I want people to understand that, the medications can be very helpful for severe, moderate to severe disease with what we call the brain-gut connection. And some people do call the gut the second brain. And it's very interesting because we have a whole set of nerves around our GI tract called the enteric nervous system. And you might have heard about the brain-gut connection, the brain-gut axis. But there is a lot of interesting findings and benefits in knowing and having a doctor who knows how the medication sometimes can affect the gut and the serotonin receptors on the gut. And sometimes these medications can help with the well-being and the coexistent anxiety or depression. What I do sometimes is I draw a line here and here, and I say the medications might work here and here. But again, this talk is more about holistic treatments, but I want you to understand that there's a lot of help out there. And sometimes it's a combined effort. Sometimes if patients are very depressed clinically and they can't think through it, they have trouble concentrating or focusing, then sometimes the medications can be helpful, for a 6-month to 12-month period, depending on what the doctor thinks, but with the patient. But sometimes that's what's needed to get over the hump of being able to do the cognitive behavioral therapy work, if that makes sense. I'm going to talk last about a type of biofeedback, which is called free spirit. And this is interesting because I've been part of this at Alleghany Health Network, and we did a quality improvement program about 4 years ago where Highmark wanted to look at patients that had panic disorder and see if this biofeedback device helped patients with their panic attacks. Okay? So this kind of goes with the model that we talked about with hyperventilating and increasing panic. So this is a treatment that we offer at Alleghany Health Network for the management of panic attacks. And I've done it with about 30, 40 patients now, and it's been very positive. Now, it's not for everybody, but I want to show you that this is part of the holistic approach in targeting the fight or flight response and the relaxation component of anxiety. So what patients do, it's pretty neat. It's for a month, and they get to see their carbon dioxide level, their CO2 level, and how fast they're breathing. And it's neat because they're guided with this device on how to slow that down and how to, and I coach patients at the same time with using their belly muscles to breathe instead of breathing up here. So sometimes it really helps with, for some patients, with that feeling of not having control and dealing with the uncertainty of panic symptoms. And we're starting to look at it in PTSD as well. So in summary, anxiety and depression are common in IBD patients as well as the autoimmunity population. I want to target the unique patient experience, and there are a lot of treatments that can help with symptoms and quality of life, and promote wellness is our goal. Thank you.
Questions for Dr. Kaplan?
Oh, thanks. It's called Mind Over Mood by Greenberger and Podesky. M-O-O-D. Yeah, like your mood, yeah. Oh, sure. I think it does with respect to stress, and we are learning a lot about inflammation and depression and anxiety. Does that make sense? So there are things that we don't quite understand yet, but in the whole fight or flight response with autoimmunity markers, in targeting the whole person, it can help with, we know that if we treat anxiety and depression, it does help with flares and in other periods. So I do believe that it's a combined look. Does that make sense?
Dr. Abdulbaki?
Question is fecal transplants for? Yes. For what particular? People who have Crohn's disease. Yeah, so let's see if you can hear me.
So Dr. Abdulbaki, you'll be hearing from after lunch. He is the director of our Centers of Excellence in both celiac disease and inflammatory bowel disease.
So I'll quickly answer your question. For fecal transplants for inflammatory bowel disease have not been proven to work successfully. They have been used in combination with certain therapies right now, but they are at best, 15 to 20% successful if used very, very diligently. That means multiple transplants done like about 4 times a week for a good 6-week period. So they're not there yet.
Yes.
So your question is about Ativan, like benzodiazepines, and what to do if they're on the medication. That's a very good question. And in looking at each patient, so understanding the patient's conditions, right? What it's being used for, how long they've been on it, side effects, all that, right? So, and looking at other alternatives. And sometimes that's where it's very helpful to have a whole approach in looking at those components, because that is something that most usually has to be tapered. And so when you, depending on how long they're on it, so if they're on it a very, very long time, then in the process of tapering it, that can be an exposure. So it's working at all levels. That's where sometimes working with the breathing, the free spirit, an alternative medication, minimizing caffeine, looking at what safety behaviors. So that, I do both meds and therapy, so that's why I'm talking about all this. But sometimes you have to have a team approach. Right. So that might be able to, sometimes it's also motivation can be a big factor. And it's looking at all those components and whether they're in a major depressive episode, because anxiety tends to be more chronic, but comes out with stress. Depression often is more episodic.
We have time for one more question.
And so your question is about, sorry.
Question? So the question was chicken and egg, anxiety and inflammation, and feeding off of each other. Is that? Okay.
I agree with you. That's a very good question. And I think that's in the pipeline of the future. I know, for example, in the GI world, they've looked at some studies with looking at blockers, like CRH blockers in the brain, okay? And so far, you know, some of the interesting medications that we're using block chemicals such as glutamate that may be part of that system as well. I think that that's in the pipeline, and Dr. Manzi may want to comment on that.
Well, I can comment a little bit on that. So just to answer, I would probably be brief by saying there's a lot of smoke but no fire that we can tell of. The studies on glutamate and certain metabolites, so they feed the body certain things that kind of break down in the brain to see if there's certain centers in the brain that are actually hyperactive and functioning at a time of stress. And they're trying to find out if somebody who has active inflammation has active disease or active signs in the brain that are saying that you're anxious. But the problem is they're only testing patients yet in a situation where they're actively inflamed or when they actively have symptoms. So there's no study to my knowledge yet that actually put people in a very perspective manner and said, you know what, let's say you have inflammatory bowel disease, we're going to do a colonoscopy every month and we're going to find out if at any given time you have any inflammation, but also at every month you're going to do an MRI of your brain with that kind of testing, and to correlate whether it's happening together or it's happening one precedes the other or the other way around. So we don't have an answer for that just yet. So I'm with you, chicken or the egg, I don't know.
Yeah, a great question. And from our perspective, the first step is to recognize it and to take it seriously and bring our multi-specialty team together and try to dissect that. So paramount importance to us. So thank you for that. Thank you, Dr. Kaup. So in keeping with our theme of holistic care for the patient with autoimmune disease, I am thrilled to welcome Dr. Robert Phillips, who is founder and director of the Coping Counselors at the Center for Coping. Dr. Phillips is a licensed psychologist. He's been in private practice since 1975. He is a highly sought-after speaker and has published over 40 books on the topic of coping with physical ailments. Dr. Phillips is on the board of directors of ARDA. He served on the board of the Lupus Foundation of America, the American Heart Association, and his most recent publication in 2018 is Newly Diagnosed, Now What? 153 strategies to help you take action and cope after your medical diagnosis. And Dr. Phillips will be speaking to us on coping with autoimmune disease. Dr. Phillips.
Originally, when I came up, I was planning on saying good morning, but now I'll say good afternoon. All right, let me take a look at this thing. You've been hearing a lot about facts related to autoimmune disease, things that you should know, all the facts, etc. But what we're going to do is we're going to talk about what to do. That's where coping comes in. So hopefully this will help to serve as an umbrella for everything that you've learned beforehand and everything that you will continue to learn after this presentation and after lunch, so that you can put it all together in a package that will help you deal with it. Given the time, I'm anticipating to hear some growling from the audience. I know it's not you growling at me, but it's rather your stomachs looking for food. So I'll try to go through some of the preliminary stuff quickly and then spend a little more time talking about some of the coping strategies that you can use. We use at the Center for Coping, which is my practice on Long Island, a 5-step approach to coping with autoimmune disease and coping with any of the medical illnesses that people have to deal with. The first step is setting the framework. The most important first step is to get a notebook. Why? You want to crystallize all of the strategies that you're going to use, but you also want to crystallize the things that you want to work on. Each person is different. Each person will experience different manifestations of disease, different problems coping. And so the more notes you write down, the more it'll help you to organize what you're dealing with and what you want to do. Being a self-advocate means taking care of yourself. You are the most important person living with your condition. Therefore, you have to be at the top of the hierarchy, and everybody that you work with and everybody that you associate with comes underneath that. Part of being a self-advocate is to learn as much as you can about your condition. My recommendation always is for any books or articles online that you may read, make sure they are current and make sure they're reputable. Second step is to identify your needs. If you take 100 people dealing with the same autoimmune disease, they're going to have a lot of different needs. So you want to figure out what you want to work on as far as coping is concerned. I use the acronym SPEAK to stand for the 5 main categories of things that people have to cope with. The S stands for social factors. How has the condition affected your social life, friendships, things that you do? The P, physical factors, dealing with your symptoms, medication, costs. The E, can anybody guess what the E stands for? Eating? Wrong. But I accept that because you're hungry, so that's why. Environment is also good, education is also good, both wrong. Emotions. Emotions, because emotions, as you've been hearing, as you heard from Dr. Kaplan, and you've heard from other speakers as well, emotions are part of the mix. What are some of the most important emotions that people deal with in dealing with autoimmune disease? Fear, anxiety, anger, depression. How many people here have ever been depressed? Okay, about half the room raised their hands. The other half are too depressed to raise their hands. The A stands for activities, the things that you do, and your condition can certainly have an impact on those activities, and as such, you want to cope with that. The K, I won't ask you if you know what the K stands for. The K stands for kin, because family is a very important component in coping with autoimmune disease, but there's no word in the English language called SPEEF. So I use the word K to complete that word. All right, so what you do with your notebook is think about your own situation and jot down the specific things, using the word SPEAK as an initial guide, the things that you want to work on. What do I want to deal with better? In what ways do I want to feel better? Be your own self-advocate. and then start setting your goals. What are the specific goals that you want to use? Here comes another acronym. I use the word SMART to delineate how you should be structuring your goals to make them work for you. Specific, measurable, achievable, realistic, and time-bound. So using those letters and those words, would a good goal be, I want to feel better? No, it's much, much too generic. We know that's the overall goal you're trying to achieve, but if you really want to do something to help yourself, if you really want to cope more effectively, you want to set specific goals that are also measurable, achievable, realistic, and time-bound. Some of the things that I am speaking with you about are things that I might cover in a 3-hour presentation. To speak about it in 25 minutes means I have to move very quickly. But I make myself accessible to questions anytime during the talk, during lunch, or by phone or email afterwards. So if you have questions about any of these things, please feel free to let me know. So now let's assume that this were a 3-hour presentation and you've already figured out what some of your pinpointed strategies of need are, what the things you want to work on, and what goals you have. Now let's talk about strategies. What can you do? You heard Dr. Kaplan talk about relaxation techniques. These are all my pets. No, really not. How many people here know how to relax? Okay, about half of the room raised their hand, the other half are too relaxed to raise their hands. When we talk about relaxation techniques, we're talking about clinical relaxation techniques. We're not talking about listening to music, taking a bubble bath, things like that, all which are valuable, but not under the umbrella of clinical techniques. So here are a sampling of relaxation techniques, and there are many more. Muscle relaxation, and you heard progressive muscle relaxation mentioned earlier. Biofeedback, you heard about the free spirit technique, but biofeedback can be useful for many symptoms, both physical and psychological. Meditation is what I call a passive technique because you're not doing anything with your body as opposed to muscle relaxation, which uses your muscles, and hypnosis. How many people here would like to learn a relaxation technique? Okay, I'm going to teach you one, but at the end of my talk, because if I taught it to you now, you'd be too relaxed to hear anything else that I had to say. This way, I've been assured that if you learn a relaxation technique right before lunch, it'll help you digest your lunch that much better. So let's move on. Improving your thinking. We're talking about cognitive techniques. The way you think can be your best friend or your worst enemy. The difference between happy people and unhappy people is not whether or not you have negative thoughts. It's how you deal with the negative thoughts that you have. How many people here have ever had negative thoughts? Okay. By the way, I'm asking that question because it gives you some exercise, you know. I pretty much expect everybody has had those negative thoughts. The goal, though, is not to let those negative thoughts proliferate. If they do, it becomes like a runaway train and can be contributory to anxiety, depression, any of the negative emotions that we've been talking about. So the caption of this photograph is, it's all the way you look at things. So here are a sampling of cognitive techniques, things that you can do to work on your thinking. One of my favorites is called cognitive restructuring, where you use your notebook and any negative thought you have, you write on the left side of the page. Now, in Dr. Kaplan's slide, you saw 4 examples of negative thoughts that people might have related to their medical condition. What you would do is whatever negative thought you have, write it on the left side of the page And then on the right side of the page, try to come up with a realistic but more positive way of thinking. So for example, if I were to do a survey of the negative thought that I have heard more often than any other in my 40 years of specializing helping people deal with medical problems, it would be, I'm never going to get any better. That's a pretty heavy thought, pretty negative. And what happens is if people are absorbed in that way of thinking, they're consumed by it, and the negative thought breeds. So it starts off, I'm never going to feel any better, and then it becomes, there's nothing I can do that's going to help me. I'm going to get worse and worse. My symptoms are going to keep getting worse and worse. I'm going to have less and less ability to do anything. I'm going to be less and less able to get out of bed. I might as well pull the blanket over my head and just die. It breeds. So we need to be able to jump in and change the thought, but it's got to be realistic. On the left side of the page, if you write down, I'm never going to feel any better, and on the right side of the page, you write down, of course you will. Tomorrow you'll feel wonderful. Is that realistic? No. And if you put it down, your mind is just not going to buy it. So how about this as an alternative but more realistic suggestion? How do I know I'm not going to feel any better? Isn't it possible that I can feel better? And as long as it's possible that I can feel better, why am I convincing myself that I can't? See? That's the kind of thing that you can do to stop that runaway train. If you take your negative thoughts and write them down and then ask yourself, what would be a better, more positive, realistic thought? What would somebody else say if they had a better way of looking at things, if they had a better attitude? There is a positive response for every negative thought you could have. And what I will do is offer you my challenge, as I do to every group that I speak to. If you come up with a negative thought and you are not able to come up with a positive response, email me. I'm serious. Email me and tell me the negative thought you can't come up with. The only thing I ask, I'll give you my email address in a little bit. The only thing I ask is in the subject line of your email, please put down your name and that you saw me speak here. This way I will know that it's not a pharmaceutical company in Canada trying to sell me Viagra. Another cognitive technique. Positive affirmations. These are the positive things you say to yourself. Again, you want them to be realistic. But the more you say them to yourself, the more you internalize them, the more you absorb them. So when you say things to yourself like, I can do better than I'm doing right now. I can feel better, I have to work on it. I can focus on the positive things in my life instead of dwelling on the negatives. Any of those things can be useful as affirmations. And my recommendation is jot them down either in your notebook or even on an index card and say them out loud to yourself several times a day. Saying them out loud is better than just thinking them, because what you're doing is you're tripling the effectiveness of the affirmation. You're reading it, you're saying it, and you're hearing it. Thought stopping. You ever find that you get a thought in your head, an upsetting thought in your head, and you just can't stop it from affecting you? Stop it. Stop it by distracting yourself. Stop it by slamming a book on a desk. I'm going to suggest to you, if you want something amusing, but something that speaks to this point, how many of you have ever used YouTube? Okay. Your assignment, go onto YouTube and in the search line, write in Bob Newhart, stop it. I promise you, you will be happy that you did. I'm not going to tell you any more. Bob Newhart, the comedian, stop it. Bring up that video, watch it. And if you'd like to let me know what you thought about it, you can email me. Compartmentalization. Let me tell you what I mean by this. Everybody has negative thoughts that are realistic to some degree. Let's say you're getting ready to go for an MRI. The thought pops into your head, I'm worried about what the MRI is going to show. Well, you can't tell yourself, don't think that way, don't think about it, because you really don't know. But you do have the ability to compartmentalize. Take that thought, especially because there's nothing you can do about it until you get the results of the MRI, and put it in a box. Leave it there, and then focus on everything else. Also part of step 4, communication strategies. How many people here communicate? Exercise time, exactly. So who do you communicate with? Friends, relatives, doctors, spice. Spice is plural of spouse. Whoever it is that you communicate with, you want to be as effective as you can in your communication. So here are some very quick suggestions for communication strategies that you can use. Notice what I put as number 1. There are times you can improve your communication just by saying, let me listen a little bit more. Now, I'm sure everybody out there is saying, I wish my relatives would listen to me a little bit more. Well, that's true, but you can set a good example for them. Ask questions rather than making statements. If you want to say to somebody, I really don't like that you did that, you could put that in the form of a question. Can you understand that I might not like that you did that? It engages the other person more in your conversation, makes them more willing to listen. Eyeballing. Have you ever had a disagreement? Yeah. If you have a disagreement, try to look at the issue through the eyes of the other person. That doesn't mean you have to agree with them. But by understanding where they're coming from, you have a heads up in being able to work out that disagreement. Negotiating. You're having a conversation with somebody and you're looking at things from 2 different points of view. You want to do things 2 different ways. Don't feel like your suggestion has to be this way of doing things. Negotiate. Go back and forth, because your goal in any communication with somebody else where there is a disagreement is to come up with a win-win solution. The caption reads, 2 things to remember in life. Take care of your thoughts when you are alone, and take care of your words when you are with people. Benefit from humor. You've heard the saying, laughter is the best medicine. It's definitely true. And I have done presentations just on that, just on humor. And I can literally say I had my audiences rolling in the aisles. But they all felt better when they left. So what can you do for humor? My doctor told me to avoid any unnecessary stress, so I didn't open his bill. Why are there never any good side effects? Just once I'd like to read a medication bottle that says may cause extreme sexiness. Okay, so we've talked about some of the basic categories of coping strategies. There are far more that can be tailor-made to meet your needs, but we only have time really for this kind of an overview. Now the goal is put it all together. To implement your program, you want to prioritize. If you come up with a number of goals and a number of strategies, decide what you want to work on first. Nothing motivates effort more than success. Agree on accountability. What does that mean? Well, obviously, you're in charge of your own self-improvement program, but if you realize that it might help you to have somebody working with you to help you to reinforce what you're doing, then try to be accountable to somebody else. A supportive friend or family member can help a lot. Schedule your strategies. If you decide to do relaxation, such as the quick release that I'm going to teach you in a moment, schedule a time of day that you're going to do it and stick to it. Don't just say, well, I'll use my strategies whenever I get around to it, because guess what? I also do a presentation on procrastination, but we'll talk about that later. Use a checklist so that everything you do and everything you accomplish, you check off. Those check marks make you feel good, don't they? The more checks you have, the more you'll keep on checking. And conquer procrastination. As I mentioned to you, evaluate your progress. Stay on top of what's happening, what's working, what's not. See how you can tweak the things that are not working and emphasize the things that are. And then consult with others. There are a lot of really, really wonderful people out there that you can work with if you need that professional help in dealing with a problem coping. Here's my therapist. That's my granddaughter. Trying to train her the right way. Okay, how many people are ready to learn the quick release? All right. Now, the good news for those of you that are hungry is that this procedure takes 2 minutes. Okay, it's a quickie, that's why it's called the quick release, and you release tension, which is why it's called the quick release. What you're going to do is, if you have something on your lap, if you can put it on the side or put it somewhere where it's not intrusive, uncross your legs, put your hands on your thighs or on the arms of your chair, and let me describe it to you very briefly, and then I'll guide you through it. The whole idea of the quick release is for you to release tension that builds up in your body. That will help you in scores of different ways. And what you do is you take a deep breath and you hold, no, not yet. Some people are so thrilled when I start going, especially when I tell them to close their eyes, that they just want to do it right away. No, in a minute, I'll tell you. You'll close your eyes, you take a deep breath, you hold your deep breath, and while you're holding your breath, you tense up as many muscles in your body as you comfortably can. No tightness to the point where you feel like you're going to pop a blood vessel. And if you're dealing with any type of pain, let's say you have arthritis in your hands, you don't have to squeeze your hands. The goal is not to cause pain, it's just to cause gentle tension, which will help you to relax when you release it. So you're going to hold your breath and you're going to hold the tension for 6 seconds. Then you'll let it out, keeping your eyes closed, breathing rhythmically and comfortably for 20 seconds. Now, when I teach patients the quick release, and by the way, I've taught this at meetings all over the world, I do it 3 times because that gives them a chance to really get into it and see how it feels. But if I did it 3 times here, I get one of 2 reactions. Either people would fall asleep and be on the floor, or people would start throwing things at me because they want to go eat lunch. So we'll do it twice, and I guarantee you'll get the feel of it. Is everybody ready? Okay, close your eyes. And before we start, I'd like you to think about what somebody would think if they walked into the room right now. They would think this must be the most boring speaker to ever be at West Penn. Okay, breathe comfortably for a couple of seconds, and now take a deep breath. All the way in, hold it, and gently tense your muscles. Gently tense your hands, squeeze your legs together, grit your teeth, squeeze your eyes, feel the tension. And now relax. Keeping your eyes closed, let your breath out in a whoosh, and now breathe rhythmically, peacefully, comfortably. And every time you exhale, allow more and more tension to drain out of your body. Just let go. Just relax. Breathing rhythmically, peacefully, comfortably. Take a deep breath all the way in, hold it, and gently tense once more. Feel the tension, feel where it is, and now relax. Let it all out. And continue breathing rhythmically, peacefully, comfortably. And allow soothing feelings of relaxation to spread throughout your body, from the top of your head to the tips of your fingers and toes. Keep relaxing. Feel the relaxation. Keep letting go. And when you are ready, you can open your eyes. How'd that feel? You feel yourself getting ready to digest lunch? Okay, so for anybody who would like to get in touch with me, here is how you can. My telephone number on Long Island and my email address. If anybody would like to receive an MP3 file of the quick release with me doing that, just send me an email, put your name in the subject line, request it. I will send it back to you. Okay? Very simple. Let me leave you with the motto of the Center for Coping as I thank ARDA and I thank the AHN for their work, the Autoimmune Institute. The motto that we use is no matter what problem you may face, you can always improve the quality of your life. Thank you.
So I can honestly say I've never heard a better right before lunch speaker, speaker in general, but to be the speaker right before lunch, that was exceptional. So if I could have your attention for just 1 minute, we've heard 4 truly world-class presentations on holistic care. This afternoon, we have 2 additional expert speakers. You're going to hear more about team-based care, celiac disease as a model, and then how changes in diet, exercise, and lifestyle can impact literally everyone in this room. I've heard the presentation, and it's not to be missed, and then we will have tours. So for lunch, we're going to take 30 minutes, which will take us to 1 o'clock. Those of you who indicated dietary restrictions, we have gluten-free, we have dairy-free, we have vegetarian. Please finish your lunches before you come back into the auditorium. And then we're going to have a final word from Virginia Ladd before we recess.
Thank you. Just a real short remark. During the intermission, several people came up to me and just really thanked me for getting the autoimmune movement off the ground. And I just like to say, it was not just me. I've always had a really wonderful team in us when we were able to afford a staff. I've had a wonderful team, board members throughout the years, wonderful team of volunteers. And you know, you could be a coach, but a coach never wins without a good team. So I just wanted to say that. And I wanted just to let people know that we are going to be making a major change at ARDA. After this long journey, I think it's time for me to step back into a different role. I'll still be involved with ARDA, particularly in the research area, which I have always loved. But we're going to have a brand new executive director and president, and he's right over there. Randy, you want to stand up? Randy and I have worked very well for the last year. We've worked together. I'm sure we're going to continue with a very smooth transition, but I feel very, very confident in handing the leadership over to Randy because he is really terrific. Thank you.
Thank you, Virginia. So while you're enjoying your lunch, our speakers, in the interest of getting to lunch, Dr. Phillips did not take questions, but as he mentioned, he'll be available at lunch. Dr. Manzi, Dr. Kaplan, Dr. Abdul-Baki. So please, while you enjoy lunch, feel free to ask them questions, and we will see you around 1 o'clock. Okay, if everyone can take a seat, we're going to get started. Dawn, can you see if anyone's in the lobby? Just call them in, please. Okay, welcome back, everyone. I hope you enjoyed your lunch. And just so you know, those extra box lunches are all being donated to the local food bank. So you're about to hear from our next two exceptional speakers. First, we have Dr. Haitham Abdulbaki. And as you've already heard, we have 4 centers of excellence. He's director of 2 of them, as he's an expert gastroenterologist and in the field of nutrition and its effect on autoimmune diseases. So he directs our Celiac Center of Excellence and our Inflammatory Bowel Disease Center of Excellence. He received his MD from the American University of Beirut, and then he trained in internal medicine with a fellowship in gastroenterology at University of Pittsburgh Medical Center. And he has been instrumental in establishing the region's first multidisciplinary center for the treatment of celiac disease. So please welcome Dr. Abdulbaki.
Thanks, Joe. Thanks for having me. All right, so I'm wondering if this is the, there we go. We're going to, they asked me to talk about celiac disease as a team-based practice, and I think that it's a perfect example of how we take care of autoimmune diseases. Now, celiac disease is one of the more benign forms of autoimmune disease. It causes a lot of trouble, but it is one of the more benign forms of autoimmune disease. But this kind of model could actually help take care of other types of autoimmune diseases. My slides may contain some information that are meant for medical providers as well, so I promise I'm going to explain everything as we go. All right. So let me first tell you about celiac disease. So some of you may have it, some of you don't. And if you don't know what celiac disease is, it's one of those autoimmune diseases where your body, just like Dr. Manzi was explaining, attacks certain organs in your body. It actually attacks your small intestine mostly. And when it attacks your small intestine, it can cause damage to the intestine, leading to malabsorption of nutrition. It could also lead to certain types of vitamin deficiencies, which have their own trouble as you go. This is genetically linked. Unlike a lot of the other autoimmune diseases, this is something that we can test for genetically, and that's really helpful. If you don't carry the gene for celiac disease, you will not develop celiac disease. But if you do carry the gene for celiac disease, then you have potential to develop celiac disease. What is that potential? 1 in 30. That means out of 30 people who carry the gene for celiac disease, 1 of them will develop celiac disease. Now, that's an average because some families have a higher risk and predominance of celiac disease because these genes kind of fall through the, they from father to son and so on and so on. And if there's like a father and mother who carry the genes and the son has a real high risk of celiac disease, then they might have more than just a 1 in 30 chance. What are the stars that align that cause the celiac disease to happen? We are not really sure. So if I have the genes, but I haven't developed celiac disease, when do I develop celiac disease? Should I be doing something to avoid something so that I don't get celiac disease? We don't know that. Well, We blame it on the lack of science. We have to wait for more research to come out. But what we do know is that when these stars align and you do develop celiac disease is catalyzed, or it gets worse when you eat gluten. So gluten is the power switch on and off that allows the celiac to be active or not. And I'll tell you all about gluten in a second. A little bit of a history about celiac disease. So we think that celiac disease happened because we exposed our bodies to wheat, and our human bodies were not supposed to be exposed to wheat. And that happened thousands of years ago when we introduced wheat into our crops, our production, to feed people. And just like dairy, if you think about why we have lactose intolerance, we have lactose intolerance probably because we're not supposed to be drinking cow's milk. We're supposed to be drinking our mother's human milk. So the fact that we introduced different types of proteins from different animals, some people couldn't tolerate it, and that's why we developed lactose intolerance. In a similar fashion, wheat carries that gluten that actually may not be tolerated very well by a lot of people. So if you don't tolerate it well, that means you are gluten sensitive. That means every time I eat gluten, I don't feel well. But is that different from celiac disease? Yes, it is different, because gluten or celiac disease is when you actually have a reaction, an inflammation, a damage to the intestine because of the gluten. So after introducing wheat to our crops, we started developing these kind of minor symptoms. It was clearly described in the 1800s that there is something that's called a wheat sickness that we weren't really aware of. Then in the mid-1990s, there was a scientist who explained it very clearly on a biopsy. They took a biopsy of the intestine. They said, look, I see damage to the intestine, and that's probably because of the wheat. Every time they eat wheat, they get this damage. And then later on, we were able to identify certain blood tests that identify this kind of damage. They can test for it with a simple blood test, and those blood tests were more common and prominent in the late 1990s. And only recently that we started to make sure that these tests are more and more accurate. There has been more awareness about celiac disease now than ever was before. We never used to look for it. It is so common. It actually, if you look at the United States, 1% of the United States has celiac disease. Out of this room, well, this is a biased room because we invited you over, right? So it's like asking someone, do you like ice cream while they're eating ice cream? So basically, we do have a very high prevalence of celiac disease in the United States. It's about every 1 in 100 people have celiac. Now, it's very much linked to genetics, as I said, and it seemed to be linked more to Northern Europeaners. So if you come from a Norwegian heritage or from an Irish heritage or from a Scottish heritage or someone from the Northern European region, then you have a much higher risk of celiac disease. If you're African American, you almost have 0 chance of getting celiac disease. So this is where I do, excuse the word, racial profiling, because when I see someone I say, hey, you're good, you're doing fine, you don't have celiac disease. But that being said, when you have the genes for celiac disease, then you could develop celiac disease, as I said, and the severity is really variable between people, and we don't have any way of telling who gets a worse disease than someone else. It favors women over men, 2 to 1 ratio, women to men. So it's more common in women. If you look at that list of foods, that picture over there, you probably think, I ate something like this today, at least once. So imagine trying to give up all of these foods if you have actually celiac disease. It's a very difficult lifestyle change to do. And often it comes in with variable clinical manifestations or symptoms, because the most common thing that comes to mind, you think, I eat gluten, I'm going to get diarrhea or pain or nausea or any gastrointestinal symptom. But the truth of the matter is only 1/3 of patients who have celiac disease have symptoms that are gastrointestinal. The other 2/3, They either have no symptoms whatsoever and they feel well, or they have symptoms outside the body. If you've probably already heard today that I have celiac disease, why do I have joint pains? Or why do I have headaches? Or even in children it presents as seizures, fatigue, neurological disorders, ataxia, which is a medical term for imbalanced walk or high risk of fall. So there's so many different symptoms in the body that could be related to celiac disease. And the only way to find out is to test for it by a blood test. But who is going to really think about testing someone with a headache for celiac disease? Your primary care doctor is going to say, oh, this is probably tension. Oh, probably this is a migraine headache. Here's some Tylenol, go home. Oh, this is a recurrent headache. Let's get an MRI. After the MRI is negative, go see a neurologist. The neurologist says, I'm not sure. Let's test for celiac disease. And that's why we get a delay in diagnosis. And sometimes it's reasonable, sometimes it's not so reasonable, because if the first doctor who saw you thought, oh, they have a family history of celiac disease, or they have a history of autoimmune disease, just like Dr. Manzi and the rest who were saying today, have a higher sensitivity or a lower threshold to actually test someone who has autoimmune disease for autoimmune disease, because they come in bundles, they come in bunches. So that's why we have to be a little bit more critical of the history. And that's why it's helpful to be working with people who know what autoimmune disease is and how it can affect you. Since it comes in variable symptoms, they've categorized it into different terms. I just listed the terms in case you're interested. But classical celiac disease means that you're having symptoms of abdominal pain, nausea, vomiting, diarrhea whenever you eat gluten. Asymptomatic means you have absolutely no symptoms whatsoever. Potential celiac disease means, oh, my sister has celiac disease, so I got tested, and my blood test was positive, but I don't have any symptoms. They biopsied my intestine, and my intestine is healthy. So I don't carry the disease, but I only have a positive blood test, which is an indicator that potentially in the next 2 to 3 years, I may develop the disease. Atypical celiac disease means I have symptoms that are non-gastrointestinal. Headaches, fatigue, what have you. Subclinical celiac disease are those of you who thought that, oh, I'm asymptomatic. That means I don't have symptoms, but I got tested and I was positive. You went on a gluten-free diet and it was a life-changing experience. And you find out like all this fatigue, I never thought I had all that energy that was taken out of me. And then you realize that you were subclinical. That means that you had symptoms, but you never were aware of them. The diagnosis, as I said, mostly is blood testing. But once a blood test is positive, it needs to be confirmed with a biopsy of your intestine. There are 2 reasons why we get the biopsy for the intestine. One, we'd like to know how bad the inflammation is so that we know how it's improving after a year of gluten-free diet. The second reason is the most highest risk of lymphoma, also known as lymph node cancer, happens within the first year of diagnosis of celiac disease. That means that we identify these kinds of cancers during the first year. Not to say that lymph node cancer or lymphoma is highly prevalent. It's extremely rare, But if it were to show up, it will show up in the first year. So it'd be very silly for us not to be looking for it and making sure that it's safe. The blood tests that we get are variable for different people of different ages. They're appropriate for adults, may not be appropriate for children. If they're younger than 2 years of age, those tests will not be positive. That's when the genetic testing comes into play. And a little word on genetic testing is that the genetic test, if you go get it done, it will be, if it is positive, if most of you here have autoimmune disease or have had a family history of autoimmune disease, if you get the genetic test, it will be positive. I promise you that. But don't get worried about it, because not all of you will develop or would have developed celiac disease. What is reassuring if the genetic test is negative, because that'll tell us you will never develop celiac disease. That genetic test is accurate 99% of the time, which is a very high accuracy level for any kind of blood test. These are the blood tests that often your doctors would order. If you look over here, the one that our guidelines in the United States require us to do the screening test called TTG, or transglutaminase. And all that means is that we are testing for the antibody or the protein that is trying to fight your intestine at the time of inflammation. All right? And that protein is very sensitive. So that means if we get the blood test, it's about 98% sensitive. So that's a pretty good accuracy for the test. The European guidelines are a little bit different. The Europeans like us to do the antigliadin plus either the endomysial or the TTG. So they like a combination of blood testing. Now that blood testing alone, as I said, is not enough. You need to get the biopsy just to confirm the diagnosis and move forward from there. You're going to see a lot of advertisements on like this young, very attractive woman who comes up on TV and says, went to my doctor and I got tested and everything was negative and I ended up going and doing this blood test to see if I have food sensitivities or if I have celiac disease. These available kits are expensive. They are hundreds of dollars out of pocket, and no insurance would cover them. Now, they may have some validity. They may have some accuracy to them. However, there's no science to interpret those. So if they're going to offer you a test, whomever offers you a test, please make sure that they offer you an explanation and a therapy. If they cannot offer you an explanation and a therapy, then why are you offering me the test? The same that applies to a doctor should apply to a company that's selling you something. So please be careful with these tests because right now, as we know, it's not interpretable. Okay? We don't have the science to interpret this. This is kind of an algorithm. I usually put this for my residents and my fellows who are training with me. I tell them this is how we interpret celiac disease in terms of testing. When we do the blood test, we kind of follow an algorithm. Are you immunodeficient? Or are you immune, or do you have your immunity? And if you have your immunity, we check the blood test. And if the blood test is high, middle, low, and this is kind of a crude way of telling someone how to interpret your test. But at the end of the day, it does need an expert to explain this to you and to be able to walk you step by step through it. And you will notice all throughout the way, it requires a confirmation with a biopsy. So everything will lead to get a biopsy, and if positive, follow through, and down the line, after a year of gluten-free, you need to be tested again. Now, the guidelines say anybody with a gastrointestinal symptom, heartburn or abdominal pain or discomfort who has autoimmune disease in their history needs to be tested for celiac disease as a screening test. After the screening, you get told by your doctor you need to be on a gluten-free diet. And it's amazing what the studies show in terms of where we get our information. So most of our information is from Dr. Google. And it's pretty good information, I have to say. There are some good stuff out there, but there's a lot of information that actually can be very confusing and very misleading. Hence, you get all the pop-ups of all these advertisements. Do this test, do that test. Do you have lactose intolerance? And advertisements for Viagra, that's another thing. But that being said, you look at how much people get information from their physicians regarding a gluten-free diet, or from a dietitian or a nutritionist. So this is pretty impressive. This is a study that was done actually in Canada when they looked at physicians who take care of patients with celiac disease, and they asked all their patients, and they said, well, where do you get your information? And that's the answer. That shouldn't be. How many of you have actually gone to your doctor, you've been told of a diagnosis, it doesn't have to be celiac or anything else, and you went out of the clinic and said, okay, I don't think all my questions were answered. Can I have a show of hands? All right. So this is a problem. So I no doubt that your physician has all the intention to provide you all the information and the treatment that you need. I've echoed Dr. Manzi's sentiments completely. It's not the problem is not with your care provider. It's the system of delivery. It's when the physician has 15 minutes to see you. Because if he doesn't see you in 15 minutes, the next person on the list, who could be you, is waiting another 15 minutes, and then you're going to be angry. And if you're angry, the physician is going to hear about it. And it's something that's actually the system is going to penalize the physician for not being on time. So we are trying to break that boundary. We are trying to break that rule. We are trying to give every patient the time that is needed. However, what we're trying to do also with implementing new subspecialists and new caretakers is to allow the patient to be sitting with the appropriate person who would be giving you the best information about that particular question you had. So for example, if you come and ask me about cooking, gluten-free, not a good idea. I'll send you to a dietitian. I know nothing about cooking. But I can give you direction about what's gluten-free and what have you. But if you want to know, well, where do I buy my groceries from? Which restaurants are good, gluten-free? Which ones that I actually, if I travel, where can I find spots that are gluten-free? These are all actually things that our dietitian is trained and is willing to provide you all that information that you need. And that's the whole goal, is that we want those people who are working with us to give you the information that is at the top of their specialty, so to speak. Now, the treatment of celiac disease, as far as I'm concerned, as a physician, you come to me and I tell you, you need to be on a gluten-free diet. We need to screen you for osteoporosis because, as you heard today, these things come in bundles. If you don't absorb your calcium and vitamin D because your intestines are hurt, you will get early osteoporosis. So that's why we screen you. We check for your vitamin levels, vitamin B12, iron, folic acid, vitamin D. These are the most commonly low vitamins. And I tell you, do not take Advil, Motrin, Aleve, ibuprofen, pain pills that are over the counter except Tylenol. And then you tell me, but I also have arthritis. And I tell you, let's talk to Dr. Manzia. Is there any other alternative to your arthritis? And that's where the communication is absolutely important. Now, the reason why we tell people who have gastrointestinal problems to avoid NSAIDs or these anti-inflammatory medications is because they have a tendency to cause injury to the intestine that mimics celiac disease or mimics Crohn's disease. So we try to avoid them if we can. Now, other things that we do, we teach our patients to make sure that they get their family members screened, since this is a highly genetically transmitted disease. We say, first-degree relatives, please get screened. You do the blood test. That's all you need to do. Get vaccinated for influenza and for pneumonia because your risk of infections with this particular disease is a little bit high, and have a low threshold to check for other autoimmune diseases. And that's why it's helpful to have a team in the background. Other diseases that could be comorbid with celiac disease, things that you probably have heard of or not even heard of. Dermatitis herpetiformis is just like a rash that happens mostly on extensor surfaces, on the elbows mostly. You can have neuropathy, you can have thyroid disease, which is one of the most common associated diseases with celiac disease. Down syndrome actually has a very high risk. Diabetes has a very high correlation with celiac disease. Infertility can happen in women. We don't know why, but infertility is a common problem if the celiac disease is not well controlled. And menstrual cycle problems like amenorrhea, which means that I do not have my periods. That's a problem. Chronic fatigue is also another issue. You've heard of that as well. So I need to work with other subspecialists. I need to know that there's a rheumatologist in the background, or a dermatologist, or an endocrinologist, or a nephrologist who would actually support me and back me up. And then from my part, from my celiac center part, I try to provide the gastrointestinal aspect of it, which also is a team of people. Because if you look at the treatment plan, as I just outlined for you, is first of all, talk to a dietitian, a skilled dietitian. Educate yourself about the disease. That would be my part. So my dietitian will talk to you about the diet. I will talk to you about the disease and tell you what to expect in terms of testing and what the next step is going to be. There's a lifelong adherence to the diet, which means it comes with a lot of burden of anxiety and change of behavior. Think of every, Thanksgiving dinner that you're not going to get stuffing. Think of every Christmas dinner when you're not going to get, Christmas cookies or, sugar cookies and things like that. So these are things that really affect you negatively. There's a lot of behavioral changes that need to happen. And these behavioral changes, you need a social worker or a behavioral therapist to help you out with these changes. So that's where the social worker and the behavioral therapist come into play. Identification of a treatment and treatment of deficiency. So that's also my part, but I also have a medical nutritionist working with me to educate you about weight loss, weight gain, and how to navigate your vitamin deficiencies. People who heal from celiac disease gain weight. Most common complaint, I wish I had celiac disease. So because they actually gain weight when the intestines heal, they're absorbing the nutrition that they were losing in the past. And last thing is finding a continuous long-term plan with a multidisciplinary team. That means if you have other diseases that are autoimmune, you need to be seen by other doctors. So that's why it's important to have this team working with you. More recently, if you look for studies, like are there other hospitals, like what other hospitals are actually doing this? And if you look for studies about multidisciplinary or team-based care for celiac disease or other autoimmune disease for that matter, you'll find very little studies. I actually found maybe 1 or 2 studies about celiac disease, and they're mostly in pediatric patients, not in adults. And the theory behind it, and there's more interest in this, as you've heard today, over the past 10 years. First of all, all institutions and hospital systems, they like to cut costs. That's always an issue for them. But for us as doctors, our issue is that we'd like to provide the care that you need in a setting that's comfortable for both physician and patient, so that the care is optimal, so that you will get the care that you need and you'll get the information you need from the right person at the right time, and there won't be any delay in care. It also improves the management of the disease itself. It also facilitates to address other concerns that are non-gastrointestinal. So if you have another non-gastrointestinal problem, I say, here's the dermatologist. Let's go talk to them. We'll find them right in their clinic next door. It also improves my adherence to guidelines. So as a gastroenterologist, if I were working alone in the middle of nowhere with no support system, I promise you there's a lot of things that I would miss. Now, they're not dangerous. All medical doctors are trained not to miss anything dangerous. But if you have a 15-minute segment and you want to see a patient, you want to make sure that you address all the key points and try as best as you can to answer the most pertinent question this patient has, the patient will walk out knowing that there's a couple of things that were not addressed and there are certain blood tests that were not done. We'll do them next time. Come back for a follow-up. We won't have that. So that's why we're trying to change the system. So as I explained to you, this is how we do it. We have a team of people, the dietitian, the nutritionist, the clinical behavioral therapist, myself as a gastroenterologist, and we also have our support system, which is the Autoimmune Institute, all together with all subspecialists in case there's any problems that need to be addressed that are non-gastrointestinal. Now, we wanted to test this theory. Right? You're saying, oh, good. Does it really work? So we published a paper. We said, let's find out if our data really works. Last year, we collected information on 2 years' worth of celiac disease patients who are seen in our autoimmune center, and we compared them to patients who have celiac disease in local gastroenterology clinics. And we tried to see, is the care anywhere different? Is the satisfaction anywhere different? So you guys are such easy to please patients because the satisfaction was fine on both sides. So the patients would be happy to see any doctor who would see them, at a good time. But at the same time, we figured, is there any good outcome from this? Are we doing something that is medically better than other clinics? And the truth of the matter, it is. It seems to us that the patients adhere more to their blood testing than in gastroenterology clinics out there. That means that if a blood test is abnormal sooner, it is addressed more efficiently and sooner and more accurately. And it will take less time to get your disease under control. That's 1. 2, we check for vitamin levels more than the local gastroenterologist. The reason is, as I just told you, when you have such a limited time to kind of take care of things, they would miss things, but not intentionally. It's just a matter of time limitations. The third thing is that we found out that our patients tend to be counseled more, be it on a behavioral therapy aspect, as well as how to avoid medications that could harm them. So actually having Casey, our pharmacist with us, is absolutely phenomenal because then we can actually go through medications, and I tell my patients, don't take any Advil, Motrin, Aleve, and things like that. So we do counsel more than we typically see in the local clinics. So the conclusion of this is that yes, a multidisciplinary approach does help, and it does really improve the quality of care. So I will leave you with this statement, which kind of summarizes how I feel about it. Right. I'll take questions. Do I have time for a question? Oh, well, I'll take questions. Yes.
The biopsy that you mentioned, can that be done through colonoscopy or is that special?
No, I'm sorry I needed to clarify that. EGD, it's an endoscopy. So they go through the mouth to the intestine, the first part of the small intestine, they get a little bite, but it's not just one bite, they have to get 5. So they get to what we call the D2 area, the second part of the duodenum, which is really about 5 inches into the intestine. They get 4 bites in 4 quadrants, 4 different areas, and they get 1 bite from the first part, the initial part right after the stomach. And that will do it.
So after you're on a gluten-free diet, you feel better. Monthly. So you have a couple of your symptoms immediately, or is it like?
So that's an excellent question too. We don't have the science to tell us who will get better or worse. It's a personal experience because it's unethical of me, technically, to know if someone has celiac disease and say, here's a cookie. Let's see how you do. So I wouldn't test that theory. It's not right. But that being said, if we look at studies that look back at patient experiences, it's very variable. Some patients come to me and say, I just, let alone, use toothpaste that actually has gluten. And you have to watch out, like toothpaste and lipstick. Imagine how much lipstick you're actually ingesting in a day. So some people say even the lipstick that I use, I get symptoms almost immediately. Some people say, I hate a whole, stuffed turkey dinner and I'm fine. But it shows up on the blood test. So that's why I don't usually trust the symptoms. I look for the blood test. Now, if your question is, how fast does the blood test rise? We also don't know the answer to that. But I don't usually check it frequently. I don't say, oh, did you eat gluten? Let's get a blood test. No, it's not necessary. Think of celiac disease as a marathon. It's not a sprint. So I'm not looking for the change that happened today or tomorrow or after tomorrow. We're looking for a long-term change in behavior. It's a long-term care thing. Okay? Yes?
Medication for celiac is an issue. So oftentimes if I'm prescribed an antibiotic and I go to the pharmacy, they can't give it to me right away because they have to contact companies.
Yeah.
Now, does your pharmacist who's on staff, does she know certain companies that you can have set up with your pharmacy, et cetera? And then part 2 of it, no NSAID, you say Tylenol is okay.
Yes.
Is Tylenol gluten-free?
That's a good. So this is a very good question. I get that question a lot. We have a pharmacist who can always contact and communicate with the companies for you, and even our dietitian can do that as well. And we always contact the companies, and I'll tell you what the answer is. I don't even need to call them. I'll tell you what they'll say. We'll say we cannot prove or disprove whether there is gluten in our products. I'll tell you what would happen. My answer to this is you need the medication because you have a disease that you need to treat. So I would not shy away from any medication if the company says I cannot confirm. So if they say, yes, it's got gluten in it, then I tell you, okay, let's find an alternative. But if they cannot confirm, I tell you, please go ahead, take your medication. It is important for your other disease. And if we want to verify if it's working or not, we'll just check a blood test next time. And if the blood test is going up, that's saying that your celiac disease is becoming more and more active, then I tell you, let's see what we did differently. If it's only that medication, then we'll probably need to get rid of it. So again, falls into the idea of this is a marathon, and I wouldn't worry about a medication that you had to take for another disease. That takes priority. I'll start with you, Ivy. Go ahead. I'm sorry. Yeah. All right. Go ahead, please. Typically not, no.
What about
Biracial.
Yeah. So yes, you could. I have patients who are biracial and have celiac disease.
I think I say I have a friend that says she's gluten-free.
Yeah.
She already knows.
Yeah. There you go, Dr. Google again. Yeah, yeah. So if this is the deal, if she's having severe symptoms, it's reasonable to get checked. I'll tell you this, what is it worth to her? Because if she feels that she wants to live a whole life of strict gluten-free, which is A, expensive, limiting from a social standpoint, and at the same time, not all foods really taste so great. There are some good foods out there, but some things don't taste so great. So if she's really willing to commit to a lifetime of gluten-free, I tell you, maybe not necessary to even get checked unless you want to know if you have potential for other autoimmune diseases. But if you only want to know the answer, do I have celiac disease? I tell her that's probably not worth it. Get a blood test once, just make sure that it's negative, and it's probably going to be negative because she's on a gluten-free diet. Anybody who wants to be tested for celiac disease need to challenge themselves with gluten. So if your granddaughter says, I don't want to eat gluten ever because I feel uncomfortable with it, I tell you, okay, maybe get a genetic test. That's probably worthwhile for her.
Okay, I just think she Googled
Trust me, everybody does. I get an hour with every patient who comes into the celiac center to see me for celiac disease, and I promise you, I spend at least half an hour correcting misinformation that the patient has acquired over time. Yes. You're welcome. Absolutely. Let me take this question. I'll get back to you, ma'am. Go ahead. Correct. Not the genetic test. Correct. Injured? Yeah, it would. It would. And the way we would find out is getting a blood test 3 months down the line. And that's why the surveillance is once you are diagnosed, you start gluten-free, we repeat the blood test 3 to 6 months down the line. If it's getting better, I tell you, keep it up. Repeat it another 6 months. And if it normalizes, when it gets to normal, then you did get a routine blood test by your primary care doctor once a year. That's it. Just to make sure it stays normal. Yes, ma'am.
You talked about consulting with pharmacists, but mine is my drug coverage. If I don't go to their specific pharmacy after I have two refills, they won't pay for it.
Mm-hmm.
Do you have any kind of workaround for that?
Well, I honestly do not have a workaround of financial concerns about your medication, but I do tell you our pharmacist will take care of it. So our pharmacist will reach out to the companies to find out if there's any medication problem. Are you talking about interrupting medication? I'm trying to get the clarity on the question here.
Just getting medication out of period.
Medication for the celiac disease.
I'm not going to your center.
Yeah.
But there's a lot of talk in the center about having pharmacists help with you. Am I going to be able to have a pharmacist from your center consult with me and then send my prescription to another pharmacy?
No, we don't need to send it to another pharmacy. We can stick to your same pharmacy. But what we would do, our pharmacist is just there for an opinion. So she's not there to prescribe, to give you medications. She's someone who's there just as an advocate, someone who's there to answer your questions, look at your records, make sure that the medications are appropriate and accurate and right. That's all. We don't interfere with your pharmacy or where you get your medications. Not at all. So wherever you get your medications, we facilitate. For celiac disease, we don't have medications, but then again, we tell you what works and what doesn't, and then we can work with your other doctors about those medications. No, we'll take one more, yeah. Yes, please.
I had a similar question about, we talk about the teamwork and working together on long-term strategy. Now is the open enrollment for insurance claims. So how you have seen we have one specialist here and
I see. So we have, so in our center, we work as a team as part of the celiac center. So if I see a patient who has, let's say, a rheumatologist at UPMC, okay? So I may not be able to have my patients see my rheumatologist to make sure that they are, their joint pains are checked and they get all the care that they need, because we are very much for making sure that you keep your continuity of care with your doctors that who've been taking care of you for long term. So continuity is really important. However, if you so choose and say, I would like to see a rheumatologist for a second opinion from this center, we're happy to facilitate. Our communication with other centers like Cleveland Clinic and UPMC is in the medical record. So we always have communication with your doctors, even though they are not within the center. If there is something very pertinent to your disease, or we have to change a medication, we have the access. We are able to communicate to your other doctors, for sure. Does that answer your question? That's a hard question to answer, but I'll tell you what. I tell you, and this is what I would do if I were a patient, go to the doctor you feel comfortable with. You need to, yeah, I understand. But if you say that I feel comfortable with our team regarding one disease, and you are comfortable with that particular doctor in another center for another disease, that's your choice. And we encourage that you go to the doctor you feel comfortable with. You're welcome to see us anytime. Like, we can find you the specialist that you need, for sure. Thank you. Cool. Thank
you. So I just wanted to emphasize a few points. First, with regard to the last question, Dr. Manzi showed you that in our first 15 months here, we've seen patients from 29 different states, including Alaska, Hawaii, California, Florida, Texas, Montana, over half the country. What do we hear most commonly? First of all, they're not sure what their diagnosis is. Number two, they have a diagnosis, but the treatment's not working. Number three, nobody has all of my records. So before they come here, we ask them, gather all your records and send them so we can be efficient. Sometimes that's the slowest part of the process, is because their PCP doesn't have all their records, and then they have to go to their rheumatologist, their endocrinologist, their nephrologist, et cetera. So we have created this institute so you don't need to go anywhere else, to be honest. And the testimonials have reflected that. A second point, you just heard from the best of the best, Dr. Abdelbaki. So all of those specialists we have, we don't just say, we need a gastroenterologist, we need a dermatologist. We recruit those specialists who are passionate and knowledgeable about autoimmune disease. So you just heard from a gastroenterologist who is expert in gastroenterology of autoimmunity. And the third point, you saw Dr. Manzi's slides of the Huddle Hall. Those of you who tour will be in the Huddle Hall in person. That Huddle Hall is where, for example, Dr. Abdelbaki said, well, patient had arthritis. I'm going to ask Dr. Manzi. Typically, a celiac or IBD patient will be seen in gastroenterology clinic. A multiple sclerosis myasthenia gravis patient will be seen in neurology clinic. Here, they're all together. So Dr. Abdelbaki might not say, you need an appointment with Dr. Manzi. He might just say, hang on a second. And he walks down 2 doors in the Huddle Hall and says, can I ask you a question? And he gets an expert answer right there. So it really does work. Okay, so our final presentation may be the most holistic of all the holistic presentations you've heard today. And I've told you earlier that I'm guessing it'll have an impact on everyone in the room because I've heard it previously. So Dr. Betsy Blazek O'Neill received her MD from the Medical College of Wisconsin, and she completed her physical medicine and rehabilitation residency at the University of Wisconsin Hospitals and Clinics. So she practices within our AHN Center for Complementary and Integrative Health, where she integrates conventional medical treatments with evidence-based complementary approaches that care for the whole person. So I'm thrilled that she could be with us today to talk about nutrition, exercise, and autoimmune disease.
Thank you. Let's see if I can get this down to my level. Okay, so this is a tough spot. Last talk of the day. Everybody's tired. They want to go home. I better say something interesting. So you've heard a lot of information today about all the people that are working on all the research about, what causes autoimmune disorders and how to best treat them and care models. But the fact is that even with the best technology that we have available, we're still not completely winning the game, right? So you guys all have access to lots of great medical treatment that's out there. And I'm assuming that all of you are still, or most of you are still not feeling exactly the way that you want to feel all the time, right? So what people have to realize is that not all of this can be done for you, and some of it has to come from within. We're still working on trying to figure out exactly how these things even happen in the first place. We have a lot more information now than we did a few years ago, but we're still figuring this out. So what causes this? Why does this happen to people? And while people are trying to figure out more of that, what we do know is that research also tells us that a lot of these factors that can be pertinent to autoimmune disorders are very much influenced by lifestyle factors. So while we're waiting for someone to come up with a magic pill that makes this all go away for us, and by the way, my bias would be that that's probably not going to completely happen. We're probably going to get better and better treatments, but people are still going to have to do some of the work for themselves because bodies have to be healthy, and healthiness comes not just from a pill, okay? So what we know is that we can manage these conditions even now with the treatment that's available. We can manage them better if we make better lifestyle choices. And what we've learned through a lot of research over the last few years is that eating healthier foods, getting regular exercise actually affects the way your body works and can help you have better metabolism and can decrease the kind of inflammation that can sometimes be out of control in an autoimmune disorder. So let's talk about food first. So, a funny thing in my line of work is that I keep coming back to stuff that my mom said to me when I was a kid, and it turns out that it ends up being true. So it really is true that people are what they eat. If you think about it, human beings are made out of the food that they eat, and they run on the fuel, which is the food they eat every day. So we're made out of what we eat, and we run on what we eat every day. So you can either be made out of really good stuff, and you can run on really good stuff, or you can be made out of junk, and you can run on junk. And I think you could kind of imagine what the difference would be in the quality of that organism. So this stuff doesn't have to be complicated. Every day people say to me in my clinic, what should I be eating? Should I eat this thing? Should I eliminate this thing? Should I eat this thing? What do you think about goji berries? What do you think about tart cherry juice? I get 50,000 questions like this every day. And really, it's a lot simpler than that. There are a lot of healthy foods out there. But the number one thing that you want to do is eat stuff that's actually food, because there's a lot of stuff that you can buy in a store and get in a restaurant that's really not even food, okay? So we're going to talk about that a little bit. This stuff is not food, okay? These are little, and I grew up with this, okay? I grew up at a time when Velveeta was as good as it got, right? Do you hear me? Who's out there with me, right? Okay. So, I grew up with this stuff, but this stuff we've now learned is not food. These are little boxes of chemicals, most of which is harmful, and it's really not helpful for people to eat this kind of stuff. So a lot of times we're talking about stuff to avoid if you have an autoimmune disorder, and by the way, for almost any other medical condition that exists, these things are also bad. You want to avoid a lot of processed food. You want to try to avoid a lot of white flour, a lot of excessive sugar. You want to avoid modified fats. So trans fats, things that say they're partially hydrogenated, It doesn't matter what the source of it is. It could be partially hydrogenated soybean oil or peanut oil or whatever. If it's partially hydrogenated, it's not good for you. Your body doesn't know how to get rid of it. And modified sugars, all of the artificial sugars and things that we find in all over in our foods now. But it's not just about everything that you want to stay away from. It's about food that you want to include in your diet. So you want to eat a lot of fresh fruits and vegetables. And, people say eat your colors. And by the way, I'm not talking about Fruit Loops, okay? When you say eat your colors, you want to eat a lot of colorful foods. So what are colorful foods? Fruits, vegetables. Actually, the things that put colors into foods are the things that are antioxidants and nutrients that are good for people. So the same thing that makes a tomato red or an orange orange is the stuff that actually is good for you. You want to eat more whole grains. So if you're staying away from a lot of white flour and a lot of extra sugar, you'd be eating some grains, but you'd want them to be whole grains so they go into your system more slowly and they have more of the nutrition that's in the outer husk of the grain. You want to eat more fish because oily fishes have the omega-3 fatty acids that we know are so helpful. And, we were taught a few years ago that all fat is bad. That's actually wrong. You want to get the good fats into your diet. Things like olive oil, nuts and seeds, avocados. They're high in calories, but that's okay if you're eating other good healthy food and you're not, eating so much of the cakes and cookies. You can handle some extra calories from your good fats. You don't have to be a vegetarian or a vegan to eat a healthy diet. I'm an omnivore. I will eat a little bit of everything, but I don't eat very much meat. I don't eat very much dairy. And when I do eat it, I try to get it from better sources. There are a lot of things in dairy products that are actually irritants to the sort of inflammatory system. And so if you're going to eat dairy, you want to try to make sure that it's organic from better sources, doesn't have these other additives. And unfortunately, in America, the way we raise a lot of our animals for livestock production and for dairy production is just not the healthiest way that we could do it, although that's starting to change a little bit. And unfortunately, the food industry is right out there trying to fool you now. The food industry knows that people are trying to eat healthier, and so they put all kinds of food out there that's supposed to be healthier. They have names like Healthy Choice. That sounds pretty healthy. But first of all, I will tell you that when your Healthy Choice is a, sort of fudge ice cream bar, you want to be a little bit suspect anyway. But this is the kind of stuff that's in a Healthy Choice premium fudge bar. Most of the things on this list are sweeteners. The rest of it is just chemical crap that people don't need. And if you've noticed, there might be 3 things in there that sound like they're actually food products, okay? The things that say milk, but it's even modified milk. So don't be fooled by the labels that are out there on the front of the package. Look on the back of the package and find out what's in it. It's really helpful if you cook more of your own food, because when it comes in a box or a package, someone else is going to put all kinds of weird stuff in there. And it is getting easier now to make some better choices when you're not at home. There are restaurants that are offering healthier choices, and you can, you have to work at it a little bit. This is the kind of stuff that the nutritionists and dietitians that were mentioned earlier can help you with. But sometimes, I pack my lunch every day at work, and I make my own food. I pack it, I bring it in, I cook it on Sunday night, and that's what I eat through the rest of the week because I don't always trust the choices that I can get around me. Michael Pollan is an author who wrote this book called The Omnivore's Dilemma, and he has 3 simple rules for healthy eating. Again, this does not have to be super hard. Eat food, not too much, so watch your portion sizes, mostly plants. Not 100% plants, but moving toward a plant-based diet. This is really the healthiest way for people to eat. So obviously, there's a lot more detail depending on what your specific problems are, if you have celiac issues, whatever. But from a general perspective, this is a good starting point for healthy eating. If we talk about exercise, now, everybody knows that they should exercise, right? We've been hearing this like forever, okay? And it is true that everyone needs exercise for general fitness, and people with autoimmune disease are no different than anyone else. They need exercise for general fitness. But people with autoimmune disease have particular reasons why they need to exercise regularly. One is that some of the treatments and the diseases themselves can have other complications. And so you might have even additional reasons to be careful about what's happening to your heart and your lungs and your muscles than someone who doesn't have an autoimmune disorder. For a lot of people with autoimmune disorders, fatigue is a real issue. And in fact, it's a reason why a lot of people with autoimmune disease don't exercise, because they feel too tired. And interestingly, most people with most autoimmune diseases actually feel reduced fatigue if they're able to get some form of exercise regularly. It matters a lot what kind you choose and how you do it and how you pace yourself. We'll talk about that a little bit more in a minute. But the other thing is, and I talk to everybody about this, whether they have autoimmune disorders or not, you know, again, most people are thinking about exercise for general fitness, and a lot of people think about it for weight loss. But probably the most important reason to get regular exercise is to keep yourself from going crazy. Because exercise is probably the most effective way that humans have to maintain their mental health. Humans are built for movement, and if they don't move regularly, they just don't feel good. So, you know, this is what a bike rack looks like if you go to a town in Holland. They literally have more bikes on the road than cars, and I'm not exaggerating. I went once to a small city in Belgium called Ghent. It's a college town. There are about 70,000 people that live there. And when we pulled into the train station at Ghent, I have never seen anything like this in my life. There was an area about the size of Heinz Field times 2 that was a bicycle parking lot, and it was completely filled. It had thousands of bikes in it. And that's, you know, just a kind of college town train station in an average city in Belgium. So there are places where people do this differently than we do. And by the way, this slide is from a talk that I gave to a group of lupus patients. But for most people with most autoimmune diseases, again, if you do it the right way, you can usually exercise without making yourself feel worse. You just have to be careful. Exercise is necessary to keep your muscle strength up. And by the way, muscle strength is one of the things that is going to predict more than anything else how people age. So people that lose muscle strength progressively as they get older, which is what happens to most people, and as they become less active as they get older, that kind of predicts when you're going to end up in a nursing home, when you're going to stop walking, when you're going to lose your independence. Muscle strength is incredibly important as people get older. Exercise will decrease joint stiffness, particularly for people that have joint diseases, if it's done carefully. Of course, you can keep yourself from getting excessive weight gain, which is not going to help you if you have certain kinds of autoimmune disorders that affect your joints and other things. And exercise also can help decrease some of the side effects that people get with certain kinds of medications. I think I've said this about 3 times, so I don't mean to be so repetitive. But I've also mentioned the mental health benefits. There have been studies where they've actually put exercise up against antidepressant medications in a well-designed research study. It's actually been done several times, and shown that regular exercise is as effective as antidepressant medications in elevating mood, and it's been shown in other studies to decrease anxiety as well. And my patients tell me this all the time. They'll say to me, you know, I used to be a regular walker and I felt so much better when I was doing that. And since I haven't been walking, I just feel like I'm depressed and, you know, kind of bummed out all the time. Excuse me. So the number one reason that I hear from patients as to why they don't get as much exercise as they would like is that they say, I don't have time. And it is true, you know, people are busy, they have lots of other things competing for their time, but when you say I don't have time to exercise, you're really saying I'm not making it a priority, because if you think about the other things that you spend time doing, I think I used the example the last time I gave this talk, you know, binge watching Game of Thrones or whatever. You know, I mean, of course, sometimes the things that you're doing are taking care of your family and going to work, and those are real concerns. And frankly, so is Game of Thrones. That's a great show. But anyway, you know, if we really think about how we prioritize our time, we really can find some time for exercise. And really, for a lot of people, particularly if you have an autoimmune disorder that causes a lot of fatigue or a lot of joint symptoms, you're going to be better off doing it in small increments anyway. And so you don't have to get all of your exercise at one time. You can get 15 minutes here and 15 minutes there, and that's much easier to fit into a day's schedule than thinking that you have to go to a gym for an hour and a half, or 2 hours. So if you think about prioritizing exercise as something that is really important for you and really important for your health, there's a way to fit it in. There's a way to do it. There's a way to make it important enough for you to take care of yourself. I love this cartoon. I saw this at a lifestyle medicine conference that I went to. What fits your busy schedule better? Exercising 1 hour a day or being dead 24 hours a day? So, people just have to think about it a little bit. And the other thing is that we really tend in our country, especially, to think of exercise as like this horrible thing that we have to slog through, and it's really just awful, But there are a lot of ways to get exercise that are really fun. I'm a walker, I'm a hiker. If I don't do that stuff, I don't feel good, and I just look forward to it. I'm in this hiking meetup group. We hike almost every weekend. It's a blast. I meet new people all the time. It's really fun. And so there are ways that you can do it that are really enjoyable, and if you find something that you really like, you're going to keep doing it. We kind of live in a society that does everything in a car, and we just don't make this a regular part of what we do. Hopefully that's changing. People are putting fitness trails all over the place, and there are hiking meetup groups, and you'd be surprised, there are meetup groups for everything. And there's, I think there's an increased awareness in our country that people need to be doing more of this, and people are starting to make it more visible, but it's definitely not where we've been for the last 20 years or so. The best choices for people that have autoimmune diseases are going to be things that are going to challenge you but not overwhelm you. So things like walking, swimming, bicycling, low impact aerobics, certain types of yoga. You do have to be a little careful with yoga if you have joint symptoms, because yoga is going to want to push you to the end of where a joint can go, and sometimes that can be uncomfortable for people. Yoga has to be done carefully in people with joint symptoms. Pilates is often a good choice, certain kinds of stretching activities. Elliptical exercise is typically a low-impact way to get aerobic exercise, and Tai Chi is fantastic for people of all types. The yoga and Tai Chi are things that I kind of call twofers, because you're getting exercise and relaxation at the same time. That sounds like an oxymoron, but you're getting movement, but it's also kind of contemplative, and you're sort of, for some people, there's even a spiritual connection with yoga and Tai Chi, and so I think you get kind of a double benefit with that. As I mentioned, if you can find something that you really like, it's going to be something that you go to more often. And I would say the same thing about food. There's plenty of healthy food that's really delicious too. And if you find healthier foods that you like, you find exercise that you like, then it's going to become a part of your habit. It's going to be part of your routine. You're always going to be turning to those things. Some people do better with inside exercise, going to a gym or having an exercise machine at home that they can use, or, even using videos. There are a ton of videos that you can use on YouTube, and you can literally Google, what's a good exercise program for someone with lupus? What's a good exercise program for someone with rheumatoid arthritis? And again, you have to be a little bit careful about Dr. YouTube also. But, if you find what seem to be reputable people, and I use a lot of exercise stuff on YouTube. It's free. It's really helpful. You can do it whenever you have time at home, and it works really great. Some people, like myself, really prefer to exercise outdoors. That's fine, but just remember, if you have certain issues like sun sensitivity, that you have to be careful about that, or, overexposure to the elements, things like that. If you have not exercised for a while and you want to get started, you really should talk to your medical provider just to make sure that you don't have any issues about getting started. Everyone should start slowly and build gradually. And be sure to set realistic goals. What a lot of people do with exercise is they say, okay, I'm super motivated. It's January 2. I'm going to just go out there and kill it, And they go to a gym and they really overdo it, and then they say, well, that was a bad idea, I can't do that, and then they just give up on it altogether. So that's really designed to fail, right? So if you just start with a little bit and you kind of see how that goes and you build on that gradually, that's really the best way to do it without shooting yourself in the foot and making yourself feel bad about not reaching some unrealistic goal. You really have to pace yourself, particularly if fatigue and symptoms are an issue for you. Again, smaller increments, lower levels of strenuousness are really best, especially when you're starting. And you really have to listen to your body. This is not kind of a no pain, no gain. I'm just going to go out there until I feel terrible, and maybe that's what I'm looking for. That's not it at all. Exercise should feel relatively good while you're doing it. So you shouldn't have to be hurting and uncomfortable and feeling bad. A walking program is the easiest thing for most people, although obviously not everyone can do that either. But walking is great because you can do it anywhere. If you travel, you can walk. You don't need a lot of special equipment. You just need a good pair of shoes. Some people do better if they have kind of a person that they do this with. I'm perfectly fine being out there every day walking by myself, but every weekend on Saturday and Sunday, I have this group of friends that we go for a walk for about 45 minutes, and then we go to a coffee shop. And we've literally been doing this for more than 15 years. In fact, I think I told this joke last time. When I was married, my husband, so it was like this group of women, and we'd walk, and then we'd go to coffee, and when I would get back, my husband would say, "How did I do today?" Because he knew what we were talking about, right? So anyway, it was great because we got exercise, but then we had some group therapy too. And, just kind of hanging out with your friends. It was really nice. So that's a habit that people could get into, something like that, where, once a week I go for a walk with my friends, and then we go have dinner together, or we have lunch together. Usually should involve food. I'm kidding. But anyway, sometimes having a little habit like that is a thing that gets you to start being an exerciser, and then you can build on that. You can sometimes walk your errands. Where I live, I can walk to the post office. I can walk to a grocery store. I can ride my bike to the Strip. Not everybody can do that, but that's a great way to get something done and get some exercise at the same time. For some people, having a dog is an exercise program, right? Because your dog has to get out there for a walk, a couple times a day. And that's a great way to just make a habit for yourself if that's something that would work for you. And then you get some pet therapy at the same time. Sometimes people have issues that require professional help. And so if you really are having difficulty getting started because of pain or some kind of issue, that's something that you can talk to your physician about. You may need to start in physical therapy, and some people will get started with activity in a physical therapy program, and then they get good advice about how to continue that on their own when they're done. So that's pretty much what I had prepared. I don't know if we have time for questions. Anybody?
Told you.
Yes.
There's been a lot on the AIP protocol, diet. There's been a lot of feedback on that, or results, or
So you're talking about the anti-inflammatory autoimmune protocol diet? I will say that I don't know a lot about that. I don't know if you guys know a lot about that. I'm always talking to people about, yeah. Hi, Thumb.
I can only comment that gastrointestinal diseases like Crohn's disease, colitis, and celiac disease, there hasn't been any proof that it actually works. But for other diseases like joint pains, no big studies. Studies that we've done on patients who have GI problem doesn't work. Pediatric groups, if you're talking about younger patients, especially in their 15 or younger, the GI diseases do respond to very specific elementals of very basic diet with these horrible. They do things like nothing like Ensure and liquid diet, so it's not something sustainable for long. But the one you're talking about doesn't work for GI.
I talk to people all the time about steering toward an anti-inflammatory diet, just in general, which is kind of what I talked about. It's getting rid of processed foods, eliminating excessive sugars, trying to eat whole foods and whole grains, fruits and vegetables, healthy fats. That's an anti-inflammatory diet, which you can Google, and there's some good information out there about that. But it's not very extreme. Do you know what I mean? It's just good, healthy food that would be healthy for anybody. Yes? Yeah, so the Impossible Meat and the Beyond Burgers, to me, even if it's plant-based, that's a lot of processed food. And if you look at how it's made and all the stuff that's in that, I eat a mostly plant-based diet. I wouldn't be eating Beyond Burgers myself because I think it's too processed. That's my opinion. But, no one's really studied it yet either. So, yes. So the question is coconut oil, and my answer is, what day is it? Because it changes every day. Okay? Yeah, so the issue with coconut oil is that even though it's a plant-based oil, it's high in saturated fats, and we've always been telling people that you want to decrease the saturated fats in your diet, which usually come from animal sources like meat and dairy. I think the real answer is there's nothing wrong with coconut oil if you eat a little bit of it in your food along with a lot of other stuff. Okay, so coconut oil should not be something that you're eating 10 tons of every day because someone said it's so good for you. I mean, people are putting it in their coffee, for God's sake, right? So, if you want a little bit of coconut oil once in a while, sure. But should you be eating coconut oil in everything that you make? Probably not. Yeah, and yeah. This is what happens with food. It's always the food du jour. Like, what's the new hot thing? And everyone, there is no thing like that, right? There's no thing like that. The healthiest diet is a diet that includes a lot of variety. There was someone here.
No, go for it.
I
I
was
actually going to ask a question.
Okay.
How about turmeric?
So turmeric is a spice that's in a lot of ethnic food. It's the spice that turns some ethnic food yellow, like Indian food, some island food. Turmeric, actually, there is some study behind that. And turmeric is a really good anti-inflammatory substance, and it doesn't seem to have a downside unless I was putting it on my oatmeal for a while, and it was turning my toothbrush yellow. Other than that, I don't know of any downside. But, again, people are going to want to put turmeric in a capsule, in a pill that has some additives in it. I would prefer if people just sprinkle the spice on their food. If you can't get enough turmeric in your food and you don't like your toothbrush turning yellow and you want to take it in a capsule or a tablet, just make sure it's really high quality and that the tablet doesn't have all kinds of other stuff in it. But I think turmeric, do you think it's good? Yeah, a lot of people with joint symptoms get relief when they take turmeric. Yeah. Okay, so here. Right. 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 We always overdo everything. Thank you. Thank you. Can we just take one more? Yes. I don't think there's any such thing as a good sugar substitute. Okay, so I think Trulia is stevia-based, right? The problem with most of the stevia-based sweeteners is they also usually have something else in them, like xylitol or something else, which, are not horrible, but still, I think you're actually better off if you want to sweeten something to just put a little bit of real sugar in it, not a lot, just a little bit, and just stay away from the sugar substitutes. That's my opinion. Because all of the sugar substitutes have additives in them. Like, it'll say it has stevia, but if you look at the label, it might have xylitol and dextrin, all this other stuff that is like, ew, Stevia is a leaf, and if you can actually buy dried stevia at a place that sells like tea and coffee, and if you want to put a little bit, as you're brewing your coffee, whatever. But I think that the packaged things have additives that I personally think are not good for people. Thank you. Thanks.
Wow, so how spectacular were those 6 speakers? What a lineup, huh? So in closing, first of all, thank you to our speakers, but mainly thank all of you. You are why we're here. and we're here for you. Secondly, please help us put ourselves out of business. Spread the word about autoimmune disease. Tell people that we're here. Third, please join us tomorrow. Shenley Plaza, the walk starts at 1 o'clock. Registration just prior to then. Looks to be a beautiful day. Thank you for taking much of your Saturday to be with us. And then finally, I know many of you are already patients here. Anyone who is not and wishes to ask about appointments, we have Laura and Dawn in the back there. Raise your hands. Okay, so please seek them out if you're interested. And the tours, the Institute is one floor